That's great. Good morning, everybody, and croeso cyfarfod Bwrdd Iechyd Prifysgol Aneurin Bevan. Diolch am ddod I chi gyd. Heddiw bydd y cyfarfod yn Saesneg. Good morning, bore da everybody, and welcome to the board meeting of Aneurin Bevan University Health Board. I just said that the meeting today will be in English, which I'm sure will be quite pleasing to people whose first language isn't Welsh. I'd like to welcome you all. I'm the Vice Chair of the Board. I'll be chairing the meeting today. And I would also like to welcome, in addition to the usual board members, Gemma McHale, who's the Chief Officer of the Community Health Council, Neil Hollis and Tracy Veal for the Audit Wales, supporting the Audit Wales report, Gwen Kohler, who's Assistant Director of Finance, who's supporting the presentation of the charitable funds accounts, and Andrew Walker, who's the Strategic Capital and Estates Project Director for the Newport East Wellbeing Centre. So welcome to you all. I have to note immediately the apologies for absence from the chair, who is unfortunately unwell at the moment, and so she's unable to chair this meeting today, and that's why I'm leading on the meeting today. I don't believe we've had any other apologies for absence, but I'll double check. Rani? No.
Enter reports, thanks.
Lovely, thank you very much. So there are no other apologies for absence. Has anybody got any declarations of interest which are in regard to the meeting today? I'm seeing lots of shaking heads. And just like to remind people today that the meeting is being recorded, and if you need to nip out or eat or drink anything, then please don't forget to turn your cameras off. So thank you for that. We move on to the next item on the agenda, which is the draft minutes of the Health Board meeting that was held on the 24th of November. And I'd like to check and see whether anybody's got any questions or if anybody feels that they are a fair record. So first of all, I'll go with questions. If people have any questions on the minutes, please. Shelley.
I just had one on page 4, and it was in relation to the report. Rhiannon reported at the last meeting that there had been a HIW report, but the report was weighted, and I just wondered if that had been received, and if so, is it going to go to the next patient safety? Just what the progress is with that, I suppose. Thank you.
Yeah. Thank you, Chair. I can pick that up. Thanks, Shelley. No, we're still awaiting receipt of the full report, but be assured when it's available, it will be presented to the next committee of the PQSOC.
That's great, thank you. Was there anything else, Shelley? No. Has anybody else got any questions on the minutes? I'm not seeing any hands raised. So are people happy to approve them as a fair and accurate record?
Yeah, I propose.
Lovely. Thank you, Paul. Thank you, Richard. That's great. So they've been approved. So we move on to the action log that's come from the last meeting. And are there any questions or comments about the action log? I think it's fairly self-explanatory. Most things have been done, and the comments are all quite full. But please, if anyone has any questions. No, I'm not seeing anything from anybody. So I think, yes, it's great to see that progress is being made. So thank you very much on that. The Chair's report, oh, sorry, apologies. The report on sealed actions and Chair's actions. Obviously, there are things that come in between board meetings that have to be signed. I just really need you today to, well, first of all, if there are any questions, but otherwise simply to be able to ratify the actions that have been taken in between the board meetings. Is there anything, Rani, that you wanted to pick up on this?
No, thanks, Shelley. Sorry, Pippa. No, thanks.
Okay, that's great. And is the board happy to ratify the actions that have been taken?
Yes.
Yeah.
Lovely. Thank you very much. That's excellent. So we move on to the next item on the agenda, which is the Chair's report. Obviously, because I'm standing in for the Chair has submitted a written report at this stage. So if there are questions, I can do my best to answer them. But I think the report itself is quite self-explanatory. But if there is anything, then please feel free to raise your hand. No. Oh, Paul, yes.
Nothing really other than can we please send our very best wishes to Anne for a speedy recovery?
Yes, of course, of course. I will make sure that the board message is passed on to Anne, and I'm sure that's something, you know, that we're all really hopeful for, that she's going to be back on her feet, fit and well before very long.
Thank you very much.
Thank you very much, Paul, for that. So we'll move on to the next item on the agenda, which is Gemma's item, and the report from the Community Health Council. So Gemma, would you like to pull out some of the sort of key highlights in this report for us, please?
Yes, please. Thank you, Chair. Morning, everybody. As usual, I'm really glad to offer the CHC's report this month. Some of the key highlights is the continued whole system pressures. We've been hearing about the access to routine services because of the staffing pressures that the Health Board is reporting that it is under, not only in Aneurin Bevan but across the country. So we feel like we're in a bit of a how it feels during the first lockdown, but for very different reasons now, that we know that the acuity of people is high who are presenting to ED and other urgent care platforms. But we know now that the staffing pressure is one of the key factors now in the pressures that we're seeing across the system. But we can only support the Health Board's work that it is doing to address the capacity issues at the Grange. We were really pleased to receive a presentation from the exec team to planning recently on the delivery of the SDEC, the same day emergency care unit, which we're hoping will be live from July. So we support that quick quick work to be put into place, and the work is going. We hear fantastic feedback from people about the work at the minor injuries units. We hear that they're seen to in a timely manner, that staff are friendly, people are getting the treatment and the diagnostics that they need in a really timely way. But equally, we're hearing good feedback about the approach of staff at the ED at the Grange. But as usual, people are reflecting the very long waits, how uncomfortable they are, and sometimes the communication could be a bit lacking. In terms of the communication with the population, we understand that you've had to stand down a number of the roadshow events because of the pandemic variant. Completely understandable. We're really interested to know what other alternatives that there could be to engaging with the population. We know that your Facebook Lives are obviously really well received by the public, and obviously any face-to-face or offline option that would be available is always welcomed by the CHC for those that might be digitally vulnerable. In terms of our winter patient experience monitoring then, I was really glad that the Health Board could support us with the launch of our winter patient experience programme. Posters for the CHC have gone up in all of the MIUs and the ED. It's supporting people to give live feedback through either an online survey, a text message service, or paper surveys available at each of the units. We've already started to receive some really positive feedback from people, which we had hoped would be the case as it has been in previous years, that people are giving positive feedback about the staff and their approach. But as the weeks go on, each unit will be offered a week 1, week 2, week 3 update, so that we can give live feedback, and then we will write a formal report at the end of April. We've recently submitted our outpatient diabetes service report to the Health Board. This was a little bit delayed from us, so my apologies for that. But as we were doing a national survey from the outset of the pandemic, we were picking up a theme from people who expressed that support from their diabetes teams had been less. And we understand that this might have been one of the teams that had been redeployed into other areas to support in urgent care areas. So we undertook this focused piece of work to really hear more and understand more about that. The key things that we picked up were there was a mix of very positive and some negative, but particularly from parents of people with children who are diabetic and the support that they are offered. So I probably just pick those up as the key things in that project, as well as just communication across the board while people are waiting for their 18-month checks. In November, we did further virtual visits with the support of the person-centred care team in the Health Board. We visited 4 wards, one in the Royal Gwent, 2 in Neverhall and 1 in Ysbyty Ystrad. We got some mixed feedback from people on B3 about the approach of staff, and even from face-to-face visits that we've done in the past. Nighttime, being able to rest at night came through as an issue. Some people felt that some of the wards could be a little bit noisy at night. And that's really a historic thing that we pick up from our visits. We've heard some lovely feedback that some staff did go above and beyond in their approach to patients, and even helped one gentleman celebrate a significant birthday while he was in hospital. So it was really lovely to see the staff really take a holistic approach to the patients on that ward. So it was really lovely for us to highlight 3-2 in Neverhall for that. Again, we've had some really mixed feedback about the menu options, but I think this varies from hospital to hospital and ward to ward, depending on the type of food that people are either allowed to eat or can eat. So the full report is a bit more specific about meal times there. And I would just raise that we did receive some feedback on a particular issue in regards to an intimate procedure that a female patient would have preferred to have been undertaken by a female member of staff, and that she wasn't given that choice. So I thought it was very important to highlight that in this report for you today. In terms of our monthly public feedback briefing that we deliver to the Health Board each month, we've had over 1,000 responses to date. This launched at the beginning of the pandemic. But again, we're hearing fantastic feedback about the vaccination and booster programme. In October and November, we hand delivered boxes and boxes of CHC paper surveys, and the teams were fantastic in handing these out to the younger cohorts. So we found out that actually younger people are not more likely to fill out an online survey. They will fill out a paper survey if you hand it to them. So whilst we did get some very vague feedback from young people, we did hear across the board that those people had more needle phobias and vaccine anxieties, and that the staff would take people aside, just offer some calm, some reassurance, and that those people felt able to continue with their vaccine. So that was really lovely to hear. I think we heard from around 600 young people during that time. So that was a lot of input in, as you can imagine. We're now hearing mixed feedback about GP services. We're getting some really good feedback about people's timely access. They're having a telephone consultation. It's determined that they need face-to-face. They're getting that. They're getting their diagnostic, and they're getting an onward referral. So we are getting some really, really good feedback about that system working. But equally off the back of that, we are still getting people's frustrations about access to face-to-face when they feel they need it. So it's a bit of a mixed field there still. We're now hearing more from people about their orthodontic waits, and also from people in their early 50s about access to cataracts operations and the impact that is having on their quality of life now. We're hearing from people who have been waiting since before the pandemic for cataracts, but they were low level need at that point, so they weren't classified as high risk at the time. They're now becoming more high risk and having to make a decision of whether they pause key aspects of their life while they're waiting. They have done some expediting with their optom or their GP to try and get a referral escalated, but these people are still waiting, and some are now not able to drive or feel able to continue with their work. So cataracts is really starting to creep up in our theme. Just some work that the CHC has coming up at the moment. We're out live with an in-hospital stroke survey, with thanks to the stroke team for supporting us to hand these surveys out to people who've suffered a stroke who are still in hospital. We've extended this survey into a 6-month survey. It was originally 3 months because the response rate at the moment is really poor, despite the fact that we are engaged directly with that audience. So we've extended that. We've sought some advice from the Stroke Association on how best to engage with people who've suffered a stroke. And we're also going to look to host 2 focus groups in April to invite people directly to a conversation with the CHC to try and encourage more feedback about stroke services in hospital. We've had live now for a few months the maternity services survey, and again with thanks to the maternity team for recirculating our survey periodically with that. I don't have any anecdotal feedback about maternity at the moment, but nothing of urgent concern has come up through the survey. We are out with the primary care out of hours and 111 service. Again, this was really poorly responded to, so I reached out to the South Wales Argus to do a piece on promoting this, and we are getting higher reach now for this survey. And our final item on this report is that we're going to be working with the person-centred care team again for a 3-ward visit to the Grange sometime in March when it's safe for us to do so. So I'm happy to take any questions that anybody has about that, please.
That's great. Thank you very much, Gemma. It's a huge amount of work that you've undertaken. It really is. I'm going to ask if there are any questions. Paul.
I think Rhiannon was first.
Sorry, Rhiannon. Rhiannon?
Thank you, Chair. It's some comments really, as opposed to questions per se, if that's okay. I just wanted to pick up on some of the issues in relation to communication. Certainly through the Quality Patient Safety Committee, there has been some feedback in relation to the experience of families struggling to make contact with wards, and our understanding of the position from a staffing perspective where we've got deficits, and so they're struggling to respond to telephone queries, but also providing proactive feedback to families, and in recognition of how challenging that is and how anxiety provoking it is for members of the public. I just wanted to provide assurance to the CHC, but also to inform the board that the executive team last week approved the reinstigation of the patient liaison officers, which was instigated during the first surges of the pandemic, was very successful and saw significant improvements in communication. So we're actively recruiting individuals into that service now. Some individuals have already started, so we expect to see some improvements. In relation to the outpatient diabetic report, thank you for that, Gemma. We are in the process of coordinating a response to that, but very helpful and some useful feedback on experiences, some really positive, as you said, but some areas for us to seek improvement, which is helpful. And just in relation to food, because Jem has highlighted that this is something that is raised quite regularly during patient surveys, and just to confirm that we are undertaking an organisational catering review that's got oversight through the Patient Quality Safety Outcomes Committee, and there's a commitment to bring a report back within the next 6 months. It's probably 5 months now, actually. So we will have an overview of the service and what improvements need to be made. So thank you very much.
Thank you, Rhi. Paul, I'll come to you, and I also have a hand up in the +22 circle at the bottom of the screen. So I'll find out who that is after you've asked your question.
I can see Tej and I can see Sarah's hands up. If that's helpful.
Thank you very much. Thank you.
Right. Well, first of all, can I put on record huge thanks to Gemma and the team for their very comprehensive report, which I think is always incredibly helpful to get the views of the patients, and in other words, patient voice from our area. I just wondered, Gemma, with regard to the GP services, not that I'm asking for the specifics, but have you got specific areas or GP surgeries where there are particular issues? Because it would be helpful to know where where we need to do some work. So was the information GP area specific?
Sometimes, so through the national report, people can either choose to give their surgery or remain anonymous, because sometimes people don't like for their story to sometimes be identifiable, so they don't always tell us which practice it is. But at the moment, I am getting some themed feedback about some surprising practices, ones that I'd not heard of as being particularly difficult in the past. So this is across all GP services at the moment, but only 1 or 2 practices have come up in the last 2 months. And I've written directly to the primary care team each time something has cropped up with those 2 particular practices. And the primary care team have gone directly to the practice managers to feed this back and try and find out what happened and whether it was isolated or something that needs to be put right. So just in the last 2 months, there have been 2 that have cropped up that were that we've not heard of as problematic surgeries in the past.
Mm-hmm. Well, I've got some other things to say, but I've noticed that I think Sarah wanted to come in. I think.
Yes, Sarah, if you'll come in on this point first, and then I'll go back to you, Paul, and then I'll go to Tej. Thanks.
Thank
Sarah.
you, Chair. So just before I confuse everyone, I'm currently Interim Director of Primary Community and Mental Health Services, as well as Director of Public Health. So it's with my interim hat on that I'm just responding to this point about GP access. So you'll recall that the Primary Care Division did a survey of all GP practices and identified their number of telephone lines, number of appointments being offered per 1,000 population, and triangulated all of that in terms of identifying practices where additional work was needed. So that work has needed to pause over the period of this latest Omicron wave, but will now be picked up again. So to answer your question, Paul, we do more systematically understand which practices do actually need to do further work in terms of enabling easy access, and the methodology is now being replicated by other health boards across Wales as a recognition of a good approach. So that notwithstanding the fact, it's also important that where we've got specific issues, that they are that exactly as Jem has described, that the CHC work with the primary care team to actually pick up on those specific issues. The more we can triangulate, the better. But I actually wanted to come in, Gemma, on your just to echo, this is a really easy to read and really clear report, and the welcome point about more positivity about the new way of working with the telephone triage and face-to-face if needed. And I wondered whether, as a next stage, we might try to work together to understand where people are saying that they wanted face-to-face and weren't offered a face-to-face appointment, and whether that actually from their point of view meant that they weren't able to communicate what they wanted to communicate, or whether actually it was more of a preference issue and that I'd rather have spoken to someone face-to-face, but actually the outcome was fine. And so I just thought, if we could perhaps understand that group a little better, that would be helpful.
Can I come back on that just on a short note, please, Chair? Thank you. What isn't covered in my report is some of the experiences of the face-to-faces that weren't given because they're going through the formal complaints procedure at the moment. So some of it is person's preference, and I try to reflect that in my report. But the 2 formal complaints that I have on at the moment, patients did go on to die because of misdiagnoses over the phone. And these will go through the formal complaints route once we've got the appropriate authority to send them on. So we are getting some serious concerns through, and we're channeling that through our advocacy service. One was a cancer that was then later found, and one was misdiagnosis that then turned into a stroke at hospital. So we are hearing of some serious things as well as patient choice too. But any joint working we can do to understand that would really be a good benefit to people.
Thank you.
Ree, do you want to come in on this specific point?
Yes, please. Thanks, Gemma. And I think they're important points for us to work with you in the detail. I'd just be concerned about us indicating that that's fact until such time that a complaint has been investigated. So just to flag that, I think is important in a public meeting. Thank you.
Thanks, Ree. Tej, was your question around GP surgeries? No. Okay, I'll go back to Paul then, and I'll come to you in a minute, Tej, if that's okay.
You raised dental issues, which seems to be, I'm seeming to get lots of comments with regard about dental surgeries, etc. So just wondered if we could ensure that's probably looked at some point with regards to our PQ committee, if that's okay. And also cataracts comes up as well. That's something else that's been raised with me, interestingly. And it is one of those areas where you quite rightly said it can affect people's quality of life in terms of their driving and certainly their work. So I'm just wondering again whether or not we just need to follow up to see whether there's anything more we're able to do on that particular issue, or what is the current state with regard to that department, and is there anything we can do to help or support in relation to that? I don't know whether I was about to say Glyn and I can see his hands up, so I'll begin an update from Glyn if that's okay then, and that's the pen paper. Thank you.
Okay, that's great. Thank you, Glyn. If I can give that to you.
Yeah, if you don't mind if I come in on this one, and Rob may be able to add some detail if it's helpful. But I mean, in terms of cataracts and ophthalmology, I mean, I think as a health board, we've been relatively successful in trying to reinstate a lot of our elective work and maintain it over the last few months. So with a few exceptions more recently, we've probably had more success than most health boards across Wales in actually trying to get back to more normal levels of elective work, and in particular around ophthalmology and cataract work. You may be aware as a board that we continue to contract with what were Care UK is now Practice Plus Group, who provide treatments in Bristol for many of our patients for cataracts as well, and that service has continued over the last few months. So we are trying to find ways of safely continuing to deliver cataract treatments through the pandemic, bearing in mind all of the other pressures that we're dealing with. And obviously I note Gemma's sort of feedback in terms of the impact that this does have on people's lives, and that's one of the reasons why we've been consciously trying to maintain some of those services as well as possible through the last few months.
Thanks, Glyn. Rob, did you want to come in on that?
Yeah, just to quickly add to that in terms of some details. So we've commissioned a service and we're expecting approximately 1,400 cataract procedures to be undertaken in Bristol for Aneurin Bevan patients. And just to let the board know that we get very positive patient feedback from that. And I think the number of years it's been running across different contracts has always been very positive experience for patients. Thanks.
Thank you. Tej, finally. I know you've been very patient.
Thank you. I'll be quick because I know we need to move on. Firstly, thank you very much, Gemma. As always, excellent report. Thank you also for helping us to challenge our own perceptions about how people engage with us. So I'm really interested to hear that young people, still, 600 people still responding. I think that's excellent, and that's fed into my thinking. So that's great. I'd just like to make a comment about the diabetes part of your report. Really interesting, and particularly I'm interested because increasingly we are hoping to encourage people to manage their conditions at home and for themselves for good health in the long term. And so we need to do as much as we can to support that, obviously. we know that this is a difficult time, and very useful that you delved in and discovered that clearly staff were redirected to other areas. I'm just keen to make sure that other services and other organisations that can support people do to the extent of their ability. So I noticed that one of the quotes that people felt, or somebody felt, abandoned and alone. And there are third sector organisations out there that can provide a certain amount of support. Clearly, they can't give that clinical support. But I'm just interested, Gemma, if anybody ever says, you know, X organisation, whether it's in this case Diabetes UK or, you know, in the area of stroke or dementia or anything, whether people see third sector organisations as part of the health service ecosystem. So there's that question, but also just a point for colleagues that I'd really like to see if we can investigate further how our third sector colleagues can support us, particularly at pinch points like we've just had.
Thanks, Tej. Gemma?
No, I'm sorry to report that nobody did refer to any outside third sector body of having been involved with them at that point. And to be quite honest, we didn't think to ask that question at that time. So that was probably an oversight from our end that we could pick up further down the line. But equally a really important point to try and cover.
Thank you. I'd be really grateful if you could ask that question. Thank you.
Thanks. Has anybody else got any questions or comments for Gemma? I'm not seeing any hands raised. Gemma, I think the work that you do in the CHC is so valuable, it's really helpful, because it isn't until we understand what our patients think about the service that we can really hope to get, you know, better experience and better quality of experience for them. And I mean, it's really good that we hear such great things about our staff, but plainly there are areas we need to look at. So yeah, we look forward to your next report, and thank you very much for the massive amount of work that you do. It really is valuable to us. So thank you.
Thank you, everyone.
If there isn't anything else on that item, we're moving on to our next item, which is about our charitable funds and the annual accounts and the annual report. And I think, Rob, that I'll pass over to you and to Tej to see if there's anything that you really want to pull out of this report for us.
Thanks, Pippa. I was going to ask Gwen to come in since she's led the accounts to give a quick overview. I'm not sure if Tej wants to add to that. Obviously, we've got the annual report in here as well, which from my perspective, I think is excellent, but I'll let the board consider that. So
that's great. Thank you. Tej, did you want to start, or are you just going to leave it to Gwen?
If it's okay, I'll leave it to Gwen, and then I'll come in at the end if that's okay, just to summarise.
That's absolutely fine. Thank you very much. Over to you, Gwen.
Okay, thank you very much. So I want to obviously take the opportunity to present the annual accounts for the charitable funds. They are requiring approval by the board before they go. They'll be sent then to or submitted to the Charities Commission by the end of the month. I wasn't going to say an awful lot in terms of the detail, but the accounts have been through the Charitable Funds Committee on the 11th of January and given sort of fair scrutiny there in terms of the detail there. There've just a few changes to the, then there's sort of more sort of technical things in terms of what you've received there, just to note really in terms of the signatories. Obviously we've updated that to reflect yourself, Pippa, instead of Anne. And then also with regards to the annual report, there were some changes around the memberships there. So that was sort of a last sort of point of detail that was picked up. So other than that, there's no changes to what you've seen there. The Audit Wales are intending to issue an unqualified audit opinion, and we'll hear from them in a minute in terms of their report there. So I'm happy to pick up any sort of queries, but you know, in terms of any queries that anybody's got, but just really asking the board to note and to approve the accounts for submission to Audit Wales and then to the Charities Commission.
Thanks, Gwen. First of all, does anybody have anything around the accounts? And if not, is everybody happy to approve so that they can be submitted as Gwen's outlined? I'm seeing lots of nodding heads.
Oh, good.
Paul, Paul, you have a question?
No, can I just say, I mean, I think that it's an very, very useful report, and looking at how we spend the money as well, I think is incredibly helpful. Looking at whether it's to do with refurbishments or patient education, looking at the research work, staff education and welfare, support costs and equipment. I mean, it's a range of really, really good work which wouldn't have been available unless we have the charitable funds, and they've been very well looked after and managed and supported by the team, etc. And obviously Tisha chairs the committee, has done a superb job in sort of with this particular area of activity, and people in Gwent have been very generous, and I think an opportunity just to say to people, thank you, and keep thinking of us.
I think you took the words out of my mouth there. Tej, did you want to comment on the report? It's a fantastic report, I have to say.
I just wanted to thank the team. I think the report is excellent, and it's really a continuation of some work that has been invested over the last few years in really trying to offer any reader, so that's this board or any member of the public, some real information and value, or an assessment of the value of what we're doing, because as I keep saying at committee, Mrs. Jones, who donates that £2.50 that she happens, that's as much as she can afford, needs to really have assurance that that money is being used for the good of people in Gwent, in consistency with in terms of the charity. So I'm really pleased with that report and the work that's being done. I think also huge thanks to the team, because there have been some quite significant challenges or challenging pieces of work in order to administer the funds effectively and efficiently this year. They have also considered and taken up the comments of Audit Wales and internal audit. So thank you for that.
That's great. Has anybody got any questions for Tej on the annual report, or any questions for Gwen on the accounts?
Well done.
I don't see. Oh, Shelley.
Pippi, I have got a question. I don't think it's probably for Tej or for Gwen. It was just on page 7 of the annual report. By the way, I agree with everyone. The annual report is absolutely fantastic. But there's reference there to a pilot in relation to Prems and Proms. And I just wondered if it's possible. I know we do get information through on Prems and Proms, but it would be helpful, I think, if the appropriate committee perhaps could have an update report on where we are across the board on the use of Prems and Proms. Some of them are electronic, I know some of them are still manual, etc. So I know there's a project, so I think it would be helpful if it's at all possible at the appropriate venue for us to have something on that.
That's great, and I'm sure we can pick that up as an action, Shelley. Tej, did you want to say something, and then I'll come to you, Rob?
So, yes, just in principle, that's spot on, actually, Shelley, and isn't something that we do systematically. So I will make a note to do that, where we have pieces of work that can contribute to the thinking in other places in committees. I will ensure that that's forwarded on. Thanks, Shelley.
That's great, thank you, Tej. And Rob?
Yeah, funny enough, I was going to say similar thing. I'll undertake to pick that piece of work up. I'll have a discussion with Shelley. It fits nicely with the work of the value team, and we can probably do a bit more of a rounded piece around where Prems and Proms are being captured all over the health board as well.
Yeah, that's really good, and I think it will be very helpful to us. So thank you for that, Shelley. Are there any other questions or comments around the report or accounts? And is the board happy to approve Approve. That's great, thank you. And,
Thank you.
and I have to say huge thank as well to the administration of the charitable funds, because they make such a difference. The generosity of people within Gwent, and I suppose outside Gwent as well, but the generosity of people is amazing, but it makes a real difference to people's lives. And it's so I want to pass on my thanks to the general public and also to the committee for treating the funds so wisely and considering all of the things that they can fund, you know, so carefully. So thank you for that. And if you can feed that back to the committee next time, I'd be really grateful. So we now move on to the Audit Wales, the audit of the charitable funds financial statements. And we have Neil Hollis and Tracy Veal from Audit Wales. If they'd like to say anything. I'm not certain which of you wishes to lead on this.
Thank you. That would be me.
I
was just really, thanks. I was really just going to touch on it very briefly. We've got the audit plan in there just for completeness, and the audit accounts report, which is the important document for today. As Gwen has said, this has been to the Charitable Funds Committee earlier in the month, and we've proposed an unqualified opinion, which will be signed by the Auditor General on Friday, following on from this meeting. There are some amendments highlighted as a result of the audit, and we've included one recommendation for improvement, work on which we understand is already underway. And we've also detailed progress on the recommendations made in the prior year. And that's all I really was going to say on this, other than to thank the Charitable Funds team, because we really appreciate their hard work this year. It has been challenging at times, and it was obviously the work they put in, not only preparing accounts, but also helping us complete all our queries and get to this point in it. I'm happy to take any questions if anyone has any. Thank you.
Are there any questions about the audit? I'm not seeing anybody's hand raised at all. It's always very nice to get an unqualified opinion, so thank you very much for that. And thank you for the report, which was very clear. So, thank you. I think we can move on to the next item on the agenda, which is Newport East Health and Wellbeing Centre, the full business case. Sarah, this has already been through the planning committee, and because of the timing, it's already been into Welsh Government. There's not very many changes, but please, if you'd like to pull anything out of the report, I'd be really grateful to hear them.
Thank you. And Andrew Walker has joined us
Yes.
to answer any specific questions as well. So as you say, Pippa, the purpose of the item is for the board to formally approve the full business case for the Newport Health and Wellbeing Centre for submission to Welsh Government. And the paper sets out the purpose, which is to confirm the change and the procurement strategy, but I think also importantly the investment objectives, which are broader than just provision of re-provision of health and care. It also includes the provision to improve integration of health and wellbeing services in Newport East MCN as well, and has been a joint development with the council and Newport City Homes. So it is in line with the Welsh Government programme for government commitment about developing integrated wellbeing centres in communities, and therefore when we get into the discussion about benefits, the benefits are broader, and we did meet with Welsh Government shortly before, so in early December, and had a discussion about what those broader benefits might be that the programme of government is seeking to deliver, and a recognition that that's probably needs further development. So we do need to be clear about the core benefits, but I think there's more work to be done about the wider benefits. So I think I'll leave it at that, and if there are questions, then I shall probably rapidly defer to Andrew to answer them.
Thank you very much, Sarah. Paul.
Just to clarify, I mean, I'm hugely supportive of this particular project. I think it has extensive benefits for that area of the community, the health and wellbeing centre or a hub, etc. And the things that I am particularly pleased about, because I think there's a significant amount of work being undertaken, and I'm fully supportive of the full business case with regard to this centre. It's got all the evidence for integrated working, which I think is absolutely essential in being formed as a hub. I've also been impressed with the extensive engagement that has taken place regarding the project. There's also clear evidence of local authority working, third sector, and very, I think, close to working with Aneurin Bevan. And I think one of the areas which I think it is very important that we do focus on, because sometimes that can be sort of it's not prioritised, but I think it is becoming a priority, is a preventative work that is possible. So bearing all those in mind, because those are all the key questions I would be asking with regard to that. And we've had a comprehensive initial sort of business case put forward. We've now been asked to approve the full business case. I think this has all the sort of makings of an incredibly successful project, and I am 100% supportive of what's been proposed.
Thank you, Paul. Shelley.
I've got two questions. One, I wasn't sure in the paper, and it's just I might have missed it, but and this is probably for Andrew. In the sort of there's a section on page 3 of the main business case at paragraph 2.8, which identifies who will be using the hub, and there's no reference there to the voluntary sector. But I just wondered if that's because they've got the Newport hub next door, and whether or not I think it's next door anyway. So that was the one question. So just if you could clarify that, because I'm sure they must be involved in the hub. And the only other thing was just on page 18, sorry, on 147, there is a reference there, and Sarah's just made the point about the benefits realisation plan. And understandably, we didn't have the annexes, but if it is possible to send me a copy of that, just so I can see where we are with it, because as Sarah said, it will need more work. I'd just be interested to see what's been submitted at this stage. So that just for me. Thanks, Andrew.
Okay. So as you rightly suggested, Shelley, I think those are questions for Andrew, if Andrew would be willing to pick them up.
Yeah, I mean, on the first point, Shelley, one of the main attractions of this development is the fact that it's actually linked to the Newport hub. And that, of course, there's quite a few difficulties initially. You get it because the site is so constrained. And we didn't originally want to have to demolish the existing health centre, which is currently linked or next to the hub. But anyway, to cut a long story short, the new building is now on the site of the existing health centre. We need to relocate that temporarily and will be physically linked to the Newport hub. And the intention is almost not to have a barrier between the two buildings, that patients, clients can go between the two as if they're one building. There's still a lot of work to do, I think, in regard to how the services actually integrate, but from a physical perspective, they are almost one in the same building, or they will be almost one in the same building. On the second point, yeah, I did send through the BRP yesterday. It's quite a large document that we spent a lot of time on with Welsh Government. We also got some external advice, I think, about a year ago, because we were struggling to identify real measurable benefits, and it is quite difficult to do that from a primary care perspective to justify an investment of £27 million. And as an aside, we had comments back from Welsh Government yesterday on the business case, because we submitted it to them back in December. And they've made some quite favourable comments about the business case as a whole, and haven't really asked for much more information on the benefits realisation plan, which is unusual, possibly reflects the amount of work that's gone into it. So, yeah, does that address your point, Shelley?
Yeah, no, that's absolutely fine. It was just I just was interested to see what you know, where it's going, particularly in relation potentially to those wider benefits. And exactly as you said, it's difficult. So it would be handy just as background information for, I personally would just like to see that, if that's helpful. But that's great. Thanks very much, Andrew.
That's great. Thank you, Sarah.
No, yes, I know teachers waiting, but it is specifically on the benefits. So Shelley, with well-being, when you're trying to measure long-term outcomes, it clearly takes time, and the approach is usually that once you've proven an intervention works, that you measure the fidelity of the replication of that intervention, so that you focus on structure and process measures, because you know if you get them right, you'll achieve the outcomes that have been achieved in the study that proved it worked. So I think, you know, it'd be fair to say that we had a discussion with Welsh Government where we were working together on how we might demonstrate the well-being element as being something that has not been there in the past. So I think it has to be a work in progress for now, and it needs to take account of the sort of wider strategic approach to well-being.
Thank you, Sarah. I'll come to you, Tej, and I think I've got Gemma's hand up as well. So I'll go to you, Tej, first.
Thank you. Again, thank you, Andrew. I think it's a fantastic piece of work. It's also testament to the partnership working that has been undertaken over some time. It's really a culmination of that, but obviously led strongly. So thank you for that. This is a comment that I made in the committee that Sarah mentioned, and I will repeat it because that has progressed a little, and that is around the funding for third sector services that would help to deliver this new model that we seek and strive for, and so what we're creating is a model, as Sarah says, that has been proven in value. And there are a number of stakeholders that are part of that, and building the box is a very strong start. So the building is a very strong start, but we then have to populate that building with those services. And in particular, third sector services really struggle with the resources for that. So Sarah, you're right, there is more work to be done. And I don't know whether this is at health board level or further up, that we need to look at how we support those services to populate those boxes. For example, and I say that we've progressed a little. I mentioned in committee that I was talking with the existing health centre there and citizens' advice around debt advice services. Since the committee, I hear that there is no funding for citizens' advice services there, and they may be offered a small pot of funding for a matter of weeks, and this isn't how how we provide sustainable services. So that's not a criticism, that is just an observation. And when we have this health centre in place, but also other health centres that we're seeking to build, we are going to need to look at a programme of working with our partners to make the most of the resources that are there, and supplementing that through whatever means that we can, in order that we can provide sustainable third sector services to support patients.
I couldn't agree more, Tej, and I think the building is an enabler, isn't it? It's an enabler for integrated working, and we need to learn from the successes and failures of other buildings that we have built. And there's a lot of work going on in Blaenavon to really realise the benefits from the building that is already there in Blaenavon. And I think the core to this is what it tends to be called social prescribing, but we don't use that in our health board because it medicalises, it's a medical model. And what we've got are things like the Integrated Wellbeing Network Programme, Compassionate Communities, which sit under the regional partnership board. So I think there's an element of what can we do through the regional partnership board to support funding, sustainable funding for the third sector for services for vulnerable groups. And I'm not sure that will help with the citizens' advice issue, because that is a broader, probably the Gwent Public Service Board agenda in terms of, and I don't want to get ahead on the agenda, but we've got the wellbeing assessment, which is core theme is all about inequality and income inequality. So I think it is, how do we work through the formal partnership structures to join up funding in a sustainable way to deliver in the buildings. But I think coming back to this particular agenda item, the building is a core enabler in terms of enabling that to happen.
Thank you, Sarah. Gemma, you wanted to come in.
Thank you. CHC has a rep on this particular group, and I get a lot of very good feedback from our representative on this. Just to pop on the record as well that we've requested that Park Surgery undertake its own separate 8-week engagement period, because it will be the surgery that will be moving furthest away from its current population. So I just wish to pop that on the record, and I've had conversations with the health board team, and they've also spoke to Park Surgery about that. And I'm really grateful that that will be taken forward as part of this engagement as well. Thank you.
Thanks, Gemma. Paul.
Can I just support something that Tisha said about the third sector and the voluntary sector? I mean, one of the issues we've had, of course, during COVID is the lack of opportunities for fundraising. You know, particularly a lot of organisations have fundraising days. I mean, things like the Royal British Legion, and I'm a great supporter of the Citizens Advice Bureau because I helped to set one up. And I think what that does, how that helps the health part of it, is obviously people go unwell, and a lot of them suffer from depression, anxiety because of money issues. So anything we can do to be helpful and supportive. So I think actually, if I could sort of ask for the sort of sustainable funding issue across the voluntary sector as a key discussion with the sort of the partners, to see if there could be some high level sort of I'm certainly funding made available, but certainly some discussions about what opportunities there are for funding to help the voluntary sector, because after all, we're talking about lots of volunteers helping in the community, and volunteers are not free. You know, there are support mechanisms required to support the voluntary sector. So I think this is something which I think a lot of the groups have been victims of what's happened during COVID. So I do hope we could be sympathetic consideration and support as a huge organisation that we are, to try and facilitate help and support for our third sector colleagues.
Thank you, Paul. And I would echo that. And I think there's a piece of work that we probably need to do around evaluating the outcomes of this case over time, and also to bring into that an evaluation of how we collaborate with the third sector in order to support our population in centres like this in the best way. And I think those two things are really kind of tied hand in hand. And I think it should come to the appropriate committee in time. Sarah, you raised your hand.
So I absolutely agree on evaluation, and certainly with the Integrated Wellbeing Network programme, sort of every bit that we add in. So, for example, the participatory budgeting, I've asked for absolute clarity about the evaluation of what that bit is adding. But I put my hand up because I come back. There is a programme for government commitment to social prescribing, and exactly what you were describing, Paul, in terms of mental well-being and the root causes of poor mental well-being is essentially what social prescribing is about, and is about solving the root causes rather than giving people an antidepressant. So I think there will, my expectation would be that there will be a programme of work over this government to strengthen where we are, so that we get to a more sustainable position, and the voluntary sector and sustainable funding has to be part of that. And then the other bit to say is that the evidence around social prescribing, the conclusion was it's not there yet, rather than, so in the world of medicine, you sort of like, there's no evidence, therefore you shouldn't do it. And actually there's a subtle difference between there's no evidence that it works or that it doesn't work. We just haven't got the evidence yet. So therefore the robust evaluation as we go along is really important, and Public Health Wales are leading on that.
Thank you. Paul, did you want to come back?
Yes, only to say that I think just a recognition really with regard to the voluntary section funding, and my experience is that, you know, budgets are sort of annual, and, you know, you are really spending a lot of time, particularly chief executive level, trying to secure funding and small pots of funding, etc. And this is why I think probably the comment about sustainable funding is helpful, so that when projects are looked at, it's not just as we'll fund you for this year, because then you spend the end of the part of the first year thinking, well, will we get it for next year? And then people saying, well, we don't know yet, because anyway, just to cut a long story short, I think if we can just address that issue as well, to have some security for long-term funding, because that's what the voluntary sector hasn't got, the security of a 2, 3, 4, 5-year budget. And if we're able to at least look at you know, a year, evaluate if it's working well, another year. I mean, obviously there's got to be some sort of performance mechanism involved to ensure there's value for money, etc. But just to bear that in mind as well. Thank you.
Thanks. And I think that's something, Sarah, that is probably an action you can take forward to put a timeline in place for us for how we're going to tackle exactly those issues.
I think it's core to the 5-year plan for the Regional Partnership Board, because increasing funding for the third sector and that sustainability question is part of the expectation of regional partnership boards over this next 5-year period.
Okay, that's really helpful. Thank you very much, Sarah. Are there any further questions? Paul, you still have your hand up? No, okay, that's fine. It's a really it's been a really good piece of work, and I'm really hopeful that it's going to make a big difference to the population of East Newport, who, you know, I think need as much support as they can get. So do I take it that the board is happy to approve the full business case?
Yes.
Yes, okay, so I'm seeing lots of nods around the table. So we'll take that as approved. Thank you so much for all your input on that, and thank you for attending, Andrew, to answer questions.
Okay, thank you.
Well done, Andrew.
If we can move on to the Gwent Public Service Board Wellbeing Assessment Consultation. Sarah, this is back to you to present.
Thank you. So the paper sets out the legal framework and the requirement for a wellbeing assessment to be undertaken by public service boards every 5 years, and the relevant legislation being the Wellbeing of Future Generations Act. This 5 years ago, the assessments were done by the individual local authorities to inform the first wellbeing plans of the newly forming public service boards, which we had one for each authority until very recently. We now have a Gwent Public Service Board, and this wellbeing assessment has been undertaken to inform a Gwent wellbeing plan, and the executive summary provides a succinct summary, and then there's the full report with the detail in it. I think, you know, when I read it, I was thinking, well, I'd be quite pleased to publish this as my Director of Public Health annual report, really, because it just completely makes the point about the determinants of health and the inequality in healthy life expectancy, and life expectancy are founded on inequality in education, employment, and housing, and experience of crime and disorder, and it's all in there. So I think as a basis on which to go forward with the work that the Public Service Board is now looking to take forward with the Institute of Health Equity around how do we really start to address health inequalities, if you read the Greater Manchester report and everything that's come out of Sir Michael Marmot's Institute, it is all about the things that are in this wellbeing assessment. So I think it's a really strong platform to go forward as the Gwent Public Service Board. But that's not a very good introduction, Chair, because I'm meant to be introducing the paper and letting the board comment, and I've just given you my strong view. But I couldn't, and I was thinking about it, I was thinking I can't see how I can introduce this other than saying I think it's really good. So but I shall be better behaved and invite board members to offer their comments.
Have we got any questions or comments for Sarah? Teach.
Well, Sarah, you said what I was going to say. I think for anyone who's ever worked in the area of tackling poverty and understood that there is a direct read across to health outcomes, will be very excited at reading this approach. I mean, we have been moving in this direction, haven't we? But to actually see it for Gwent, I think is gratifying that we've moved to that place, and I just really look forward to how we use this and what is manifested in the plans of the Gwent Public Service Board, and how we're going to work with it and make the most of the information that we've got here.
Thank you, Tej. Do I have any other questions or comments, Paul?
Just to say, I've always been a great supporter of what Marmot has to say with regard to his previous review, etc., which came out several years ago. I mean, I think this is, I'm going to go one stage further here. I think it's an excellent report, not a very good one or whatever the wording you used. I think that because it's joined up, we've got one whole conversation going on rather than several conversations on. And I do applaud all the councils and leaders of the councils, by the way, in coming together to think, OK, we are all one greater Gwent. What can we all do to work together to improve the health and well-being and quality of lives of people in our communities? And I think that's a really important sort of key message. And above all, it also does include the sort of Future Generations Act together with the social and economic duty. So I applaud all the, I think the Aneurin Bevan people that are involved, and all the councils, etc., and local authorities and others, and emergency services, all coming together to try and, do something to make a difference. And so, I applaud this initiative and think it's, it's the way forward. And well done.
Thank you, Paul. Phil.
Yes, Chair, thanks. As everybody else has said, I think this is great stuff and a real step forward. Although I think it's worth making the point that creating one public service board and agreeing something is actually only the first step. Actually, what we have to do is ensure that we actually make sure that we endeavour to deliver on the aspiration. And I just wonder whether it would be useful to think about, in terms of our policy reports, for example, whether we ought to have a box on them in future that would have a direct read across that would say something like, how does this relate to, or what would be the impact of the well-being general step forward and general footprint, to try to ensure that all policymakers are actually working in with this actually as a backcloth to their everyday work. Because otherwise it could sound like a grand plan that everybody celebrates and says, well, that's great. But actually, the proof of the pudding of this will be in the eating, won't it? So I think we need to find some way of saying that where we've gone so far is not the product; it's the start of the product. And I guess what we need to ensure is that the product is ultimately delivered. Really, I think we need to think about how can we monitor it, and how can we ensure that as a Gwent collective public service that we are trying to, all of us, work off the same page. Really, but generally, it's a great step forward.
That's great. Thank you very much, Phil. And I agree with you. It's really useful background, isn't it, to tailoring our services. I think that for me, I would have liked to have seen the statistics layered over some additional work around diversity and language, whether that be Welsh language or actually second languages more generally. And I think that might be helpful to give us some greater depth of understanding of the figures. but I would absolutely echo what other people have said around this. But Sarah, if you'd like to pick up on next steps.
Thank you, Chair. So the way the process works is, having agreed the wellbeing assessment, then the next year is spent formulating the wellbeing plan, which is what are we going to do about it. And this will go back to the Public Service Board in March, which will coincide with me taking back to the Public Service Board the formal proposal around working with the Institute of Health Equity to really take forward what are we going to do about health inequalities. So actually the alignment is there in terms of bringing them in to help us develop the plan to actually reduce inequalities based on their experience from elsewhere, their enormous knowledge of the evidence base. And I would see in the things that we might ask them to do, helping us develop the indicator set. So if you look at places like Greater Manchester, they from the very long list of things you can monitor, they picked the things that were most relevant to them. So I think that would be one of the things that we would ask the Institute to help us with. So I see their assistance as being part of how we get to a plan that is really going to make a difference.
Yes, and it absolutely, just to reflect what Phil is saying, it's something that we need at the heart of decision making, isn't it, if we want to make a difference?
Absolutely, and therefore, having agreed a plan, that we as a board are very clear that we're delivering on our parts of it.
Yes.
Which of course will be in line with the Minister's priorities around the improving population health and reducing health inequality. So I think there's the opportunity for some much closer alignment than we've had in the past.
Yes, and I think that's just really important. And I think we absolutely should thank the Gwent PSB for compiling all of this data and putting it all together. But if we could feedback about diversity, I'd be really grateful. Paul, you have your hand up.
Just a final point. Could we also include perhaps the inequalities in the COVID-19 mortality as well, and looking at the impact of that on it, because that's obviously something which has come up since the original Marmot review, etc. I think that may be useful as well. The area.
I think it's not in there, Paul, because it's still quite emerging data at the moment. So I think that is. And again, I think it's likely to be most useful at the UK level. I think the things that the Institute do, they're likely to get there first in terms of what have we learnt just about the impact of inequalities on COVID outcomes, rather than us having local data. But we can, so you're absolutely right. We do need to add that as it becomes available.
And I'm sure that you can feed that back into the PSB as well.
Indeed.
Yeah.
That's great.
Thank you for that.
Are there any other questions or comments on this for Sarah? No, it doesn't seem so. So thank you very much, Sarah. It really is a great piece of work, and please pass on our thanks to the PSB. So moving on to financial performance paper. So Rob, please take it away, as they say.
Thanks, Pippa. So what's presented is a finance report for the 8-month period to the end of November 21. The Health Board is reporting a break-even year-to-date position and a forecast break-even position as well. In terms of key points to note, there's income assumed in terms of balance of COVID funding, in terms of receipting of £19 million for that. I'll come back to that in a moment. Pay spend has increased by £2 million in the month, £500,000 of which is substantive recruitment, £1.5 million is variable pay. Non-pay spend has moved by £2 million for ICF, WISC and optometric payments, which are actually budgeted for. So whilst the spend is moving, they're a neutral impact to our position. And savings continue in line with plan to deliver £16 million as identified in our forecast. Key risks are around the implications of COVID and responding operationally to the COVID situation, significantly around workforce. Some risk, although it's low, around income anticipated for the full year position, and obviously managing recovery in the context of Omicron is creating some uncertainty and challenge for us at the moment, along with the winter situation we're facing. In terms of the forecast risk and the future, as we usually report, improving the underlying position and delivering further recurrent savings to help sustainability is something we need to focus on going forward. Since the report has been published, we have had month 9 position reported. So just a couple of key points to note on there is that the anticipated allocations for COVID have now been confirmed. So that gives us some certainty there. However, as a result of taking action to deal with the Omicron variant driving the mass vax process and some of our winter pressures, we are seeing some slippage on our recovery plans, and we're looking at what mitigating opportunities that presents to do other things for patients and staff benefit. In terms of the content of the report, variable pay remains high, and again that's reflecting the exceptional service pressures, particularly in an emergency and urgent care, and operating and continue to operate in a COVID-safe environment for staff and patients. Those costs are looking at around about £18 million a month, reflective of beds, enhanced care and urgent care services that we've needed to step up. Service recovery plans are being progressed, but as I said, there's some slippage emerging, and we're looking for alternative uses of that funding. The underlying position does remain a challenge, £20.9 million reported, and that'll have to be a key part of the IMTP process, considering how the allocation letter and the allocations we've received presents an opportunity for us to improve the sustainability of previous investment decisions and choices. And just to note, as part of that process, there's a currently refreshed approach being considered by the executive team around efficiency delivery and re-engaging staff in that message, really, because obviously there's been a lot of money made available on a non-recurrent basis during the last 2 years. Capital forecast to break even. There's some small movements around that come to year end. We're expecting that to be balanced. The cash position and the payments performance is meeting the required targets, and included in the report is a very brief summary of the key points of the allocation and the allocation letter for Aneurin Bevan. There's obviously been a previous brief issued to all the board members, but the key point for note is that in terms of new funding, rather than ratifying previously agreed funding to a recurrent position, there's a £67 million uplift for the Health Board. So to conclude, that's the overview of the position at month 8 with a quick update on month 9 on the key points. And any questions?
Thank you, Rob. Paul, first of all.
First of all, this is a very detailed report, Rob, and can I take the opportunity to say a huge thanks to you and your team for getting all this together. Obviously, with the impact of COVID, I mean, I am just simply amazed that we're in this very positive situation, and I think it's huge credit to the work that's been undertaken and the support that we've had from Welsh Government as well. So I think we need to note that as well, because I think getting to a break-even position when so many other areas of the UK are having great difficulties, I think, with the funding issue. And I think from our perspective as a board, our role is to look at the finances and ensure we've got an efficient and an effective service in place. And I think that's well evidenced in terms of the report. But I do think I would agree with you, and I think we do need to have a plan in place to look at regard to savings and the sustainability issue, because that's going to be important, I think, as things probably will be tightening up financially over the next period. So we just need to be aware of that. The only question I've got is I wonder if you were able to sort of make a comment as to where we are break even compared to other health boards. In other words, if you do a bit of benchmarking, where are we compared to the other health boards in Wales with regard to our financial position and situation. Are you able to comment on that?
Yeah, generally all organisations across Wales are expecting to achieve break-even, or where they've had financial support packages over a number of years, they're expected to hit their target levels. So for us, we are complying with Welsh Government's requirement to break even. We are seeing, as I say, we are seeing some slippage emerge in some of our plans, but we're looking to see what we can utilise those resources for, rather than get them locked into our bottom line position. The rest of Wales, I think, from my intelligence, are broadly in a similar position to us. Obviously, Omicron and the uncertainties of winter and other pressures are actually affecting everybody in a similar fashion, really.
Well, okay, thank you for that. Thank you very much.
Thanks, Rob. I'll go to you, Shelley, and then I'll come to you, Rhea, if that's okay.
Thanks very much, Pippa. Rob, but thanks very much for the report, and it is, as Paula said, very comprehensive. I've got a couple of questions which you know what I'm going to ask because I've already told you. But so the one question was around enhanced care, which is on page 235, and this is not, I understand the concept of this, and I'm not suggesting we shouldn't be doing it, but we get this report on the basis of the financial input to this, which is obviously quite significant. And I just wondered whether or not there was any work that could be done to identify whether the use of these specialist nurses can be matched against the actual spend, and then the actual patient outcomes, to assure us that we are getting value for money and that we are getting, for example, the better outcomes for patients particularly. So that's just a question about whether or not we could do that. If I just go on, I'll go on to the other questions that I have. It's on page, sorry, I've got the numbers here, except I think I got the wrong one. There's a question also around decisions and choices. I'm sorry, I haven't got the right reference number in relation to some of the sums that some decisions are being made. And these, I wondered whether or not those are decisions that are being made by exec team. And I just wondered or not whether those decisions affect the underlying deficit for next year. So those ones that you've funded this year, but without necessarily with recurrent funding, and what the mechanism for that was in terms of, I don't know, prioritising those particular decisions. And I know what you're saying, obviously, which is good, that the exec team are looking to bring a revised process in looking at the sustainability and savings and better use of resources. And the other question I had was around page 256, which was around assumptions, and it was around primary care contract uplifts. And it does say in there, may be fully funded. So just wanted to check how much of a risk that assumption was, Rob.
Oh, okay. I'll start off with the last one because it's easier. The allocations for primary care contractor uplifts are usually held by Welsh Government until the contract is the contract amendment is actually agreed on a national basis formally with the negotiating parties. And basically, Welsh Government have historically always funded the agreed contractual uplift to us. So there's negligible risk there. In terms of your other question, so if I start with the enhanced care piece, I think I'd agree it would be good to do a triangulation. I'll pick that up. I'll undertake that task to investigate and see how much detail we can get into in terms of triangulating the money with the service, with the workforce, and with the patient outcome. We will be able to do more analysis and present something. Whether we'll ultimately be able to get to the point of a difference in outcome per patient aligned to the financials, I'm not sure, but we will. I'll endeavour to see where we can go with that based on the information that's captured. We may have to do perhaps a case study or something like that. But happy to look at that. In terms of the decisions made and the choices to be made, there's been an awful lot of decisions made during this year because of COVID and responding to the uncertainties and taking action, basically to make sure that our patients are safe and we're able to support our staff in delivering those services. A lot of things have been considered. Whether they are required to be in place permanently or recurrently is part of the process now, where we are considering our IMTP investment profiles and priorities going forward, and our service plans. I'm sure everybody appreciates the situation that COVID hasn't switched off yet, so we're considering that in the round of everything. Yes, we've had additional funding, but we've also got certain other priorities. So there's a mix really of things that had to be done versus whether they're in line with our long-term strategic approach. And really that's what the IMTP process will draw out and put for consideration to the board. In terms of, I have mentioned around the review and a different approach to trying to drive efficiencies and savings, particularly on the back of the new financial year. So there's a process being established and started in terms of discussion at the exec team around how we can refresh our approach to doing that. Very much acknowledged that it's the human factor we need to pick up on and re-engage staff, if you like, in the thinking around. I describe it as thrift, but it's broader than that, transformation, and really getting some rigor back into what we wanted to do before COVID hit, and drive some of those transformation schemes and efficiency improvement through our new IMTP. I think that's all your questions, Shelley, but I'm not sure if I picked up everything.
Yes, thanks very much indeed. That's great. Thanks, Rob.
Thanks, Shelley. And Rhea, I'll come to you next.
Thank you. I'll just come in on the back of the enhanced care question as well, if I may. I'll obviously work with you, Rob, on that review. But I did want to give assurance that in terms of enhanced care, we've already undertaken work in this area over a number of years, and even up into the last 18 months, where we've introduced a revised framework for enhanced care. Board will be well aware that we've had ongoing concerns about the increase in dependency and acuity of patients presenting since the pandemic. And additionally, the robust approach we have to the Nurse Staffing Levels Wales Act, where we undertake an annual acuity audit. We've continued to undertake that audit in January. It's January every year. Board will be aware I present the results of that. And as such, that is clearly evidencing the increase in acuity and dependency and what that means in terms of the staffing requirements. So notwithstanding the question about outcomes and impacts, I think it's easier to identify the impact when we do not have enhanced care covered, when we have significant serious incidents and events that occur. So I just wanted to flag that and to assure that it is a robust approach. That isn't saying there isn't more work to do. And again, I've just flagged the proof of concept that we were undertaking in Isbutty and Aneurin Bevan in relation to meaningful activities. And one of the outcome indicators was for us to explore that with the input of meaningful activities for patients, particularly those with a cognitive impairment, that we may reduce the requirement for enhanced care because of those activities. And that's work that's ongoing and being rolled out across the Health Board. So just to pick up on that one, I did just want to flag, if I may, Chair, Rob's comment there in relation to the refreshed approach to efficiencies within the Health Board, and acknowledge the support from Rob in his role for executives. We've recognised that this is about transformation, not a transactional approach. I think it is about reigniting and re-energising the discussions. Rob touched on the fact that obviously we've had lots of money coming into the Health Board through, as have other health boards through COVID. I think this is just about re-engaging staff on the importance of this agenda, bearing in mind the financial position that we face, but taking an approach which is about efficiency and value for money, as opposed to and reinforcing every penny counts, but just re-engaging the workforce on this agenda, because their mindset hasn't been there for very obvious reasons, but to acknowledge Rob's enthusiasm around this agenda and engaging execs in what is a very important issue. Thanks.
Thanks, Rhiannon. Yes, very much part of our recovery plans. Phil, I have you.
Yeah. Thanks, Chair. Well, Rhiannon's probably touched on some of the things I was going to ask, really. But great report, Rob, as ever, very clear, all set out in a very readable form, which is very helpful. Great to see break even this year. I guess as a board, we almost take this for granted, really, break even, because it's where we expect to be. There are many boardrooms around Wales where the concept of break even probably wouldn't even be on the agenda. So I think it's a great achievement for year on year that you managed to do this and the organisation manages to deliver it. Within that, though, to reflect some of the other points, there has been a tremendous amount of money around this year. And I guess we've been living in a bit of an unreal financial situation, really. This is probably going to change, I would envisaged over the coming years. And I guess picking up on what Rhiannon has said, we need a message out there now, a realistic message to staff about we are moving forward. We're going to move from a position of having an abundance of money, I think, to one where it will be tighter. And I just wonder, Rob, in terms of our strategic kind of thinking going forward, where would you say our top kind of 2 or 3 strategic pressures are going to come from that the organisation will simply need to be headlining, and the board will need to be cited on in terms of what are the biggies going forward that will cause us difficulties? And I guess what I'm saying, where are the real red strategic areas that we need to start to be flagging?
It's a good question. I think from my perspective, there's a couple of national issues that are interesting. Utilities, which we're all facing personally as well as corporately, that will be a big issue for us to manage. I'd also reflect in terms of where we are now and how we're currently operating in terms of the pressures we're experiencing. And I haven't got a crystal ball, but I can't imagine they're going to switch off on the 31st of March. So why I mention that is if you look, it's in the finance report, but the level of our variable pay is huge. But it's there because of the situation that we're facing at the moment and the pressures we're facing. System-wide, national issues, but they are emerging and landing a lot of those with us. So I think variable pay is an area that continues and is likely to continue as a pressure for us that we need to consider that's managed. Now, that's a symptom of the pressures we're experiencing and a symptom of having to establish more beds. Enhanced care we've just touched on, that's another piece. And the ongoing service delivery structures we've put in place. The other elements I think for next year is perhaps the level of funding. Whilst it's very positive uplift for us, there are issues around our current costs. As I said, because of COVID, will generate a likely cost pressure for next year, at least in the early part that we need to keep an eye on. And probably to flip like your question, I guess, Phil, is we do need to start thinking now around where our priorities are going to be for the short, medium and long term. I think probably we can all describe our long term priorities and objectives and where we want to go. The outer area of the rainbow, as Sarah keeps mentioning to me, and the public health upstream investment approach, but at the same time we've got the pressures of the acute setting that we are seeing from patients turn up. So it does, I suppose, in large macro terms, come to the wider recovery in response to COVID over the medium term, and there's a plethora of issues which I won't go through. But I think to nail back to the question, the exam question, it's probably utilities and workforce are our biggest stress points, really.
Okay, Chair, can I just come back? Thank you for that, Robert. I think that's kind of corral where my thinking was, really, in a sense that there are clearly some things that will cost us more money to sort, but we simply have to do it. Some of the things I know that Rhiannon's working on in terms of quality and all kinds of things, we have to spend more money on that, whether we like it or not. We simply have to do it. But the other side of that coin will mean there will be less in the pot to do some of the things that we would like to do. And I guess that's the issue for me, is where, and you've said it, where are the priorities? Because we will need at some stage to get to a position where we say we have to do this, and because we have to do this, we can't do that. And I think that's where the kind of rubber's going to hit the road a bit, isn't it? But thanks very much, Rob. Very helpful. Thanks.
Thanks, Phil. And I go to you, Leanne, first, and then Sarah.
Thanks very much. I just wanted to add a little bit in terms of, I guess, sort of some of the operational sort of response to that, which I think Rob has partly sort of covered off. It has to be a bottom-up and a sort of a more strategic approach. So I think the concept of engaging, as has already been referenced, as all of our staff in the Care Well for Less agenda, I think is really, really important. But I think the scale of the challenge that we've got financially means that there has to be full-scale sort of system transformation. And, you know, an example of this, and probably hard to believe the Director of Ops is going to be talking about transferring monies out into the community, but I absolutely will be. 2/3 of our bed base is currently occupied by patients that are very well known to us. And the reality is sort of that fragility of staffing we have, mainly focused but not entirely sort of in acute, albeit we have it in community as well, is something that is driving almost this vortex of I guess sort of inefficiency for us, even outside of the very the issues that I think worry us all around sort of patient safety and quality. So I think the sustainability of staffing and the blended approach to workforce, I think, will be really, really key, because I think that will drive, looking across the patient pathway will be massively important. And I think not least because we have to, it's incumbent on us to maximise the resource because of the scale of the challenge we have around recovery. So I think that, as I said, that transformational bit in terms of the patient, matching the patient need against where they are in our system will be a key piece of work for us, because I think the resources then follow it.
Thank you. Thank you. And Sarah, did you want to come in on workforce?
Yeah, just quickly to reiterate and support the points that have been made, really, in terms of engaging our workforce with the transformation and the efficiency and value for money agenda, which will definitely be a shift, as others have said, in terms of culture, behaviours. So that will require some OD intervention and support, which we have been discussing as an executive team, and also to support Rob's view in terms of the strategic highlight around the variable pay. The reports that Rob has presented month on month and other discussions we've had at People and Culture Committee have identified the reliance on variable pay, and that's notwithstanding that we haven't made increases in our substantive workforce over the past 2 years in particular. So it's just to support Rob's comments in terms of the focus on variable pay, but in terms of those transformation workforce models, being more flexible, more agile, and linking with our priorities.
Thank you, Sarah. And we do know that, you know, resolving workforce issues is a long-term issue as well, because, you know, people have to go through training and all sorts of things. So of course there's an impact of that, as well as using the staff that we have in the best and most efficient way that we can. So it would be interesting. I'll come to you just a second, Sarah. It would be very interesting, Rob, to see about how we can match the money to the outcomes over time. So I'll be really interested to see that. And also, Ree, I think the work going on in YAB will be really interesting to see the results of that as well. Sarah.
I just wanted to pick up on Sarah's point about transformational workforce models and the learning from how we've delivered some of the pandemic programs like the mass vaccination program, where the need to do it at speed meant we had to do mainly deploy registrants, but we've reached the point now where we understand how to do it safely with more of a non-registrant workforce under registrant supervision, and I think there's a lot of scope for that to inform our future thinking, particularly around services in the community, where we're talking about interventions that can be delivered following a programme a protocol, and importantly, therefore, provide routes into good work as part of our contribution to the foundation economy. So I think there's a real opportunity from learning from what we've done with the COVID programmes to inform how we do some of our workforce design for the future, recruiting people who can therefore do things with training, but a shorter period of training, and they're becoming very specialist in something.
That's a really good point. Thank you, Sarah. Yes, and I think, you know, the board generally would like to thank Rob and the team for great piece of work. Really good report, very clear, but it's very good to see the financial position at break-even performance and assessment of all the risks and opportunities that go on through the year as well. I think is really important. Glyn, did you want to come in on this point?
Yeah, just very briefly, really. I mean, I won't add to the discussion about the strategic areas. I think we probably all have views on that, and it would be worth having probably a separate session. It was really just to say that as part of the IMTP process, both as an exec team, we'll be looking at this more closely later this week, but also we have a board development session arranged, I think it's in February, Chair, to look at our priorities over the next 3 years. So I think the points that have been raised today have all been really helpful, and we do need that sort of strategic focus on where we're going over the next 3 years plus. But we will also need to make some decisions about what we can do next year as things emerge around actually what COVID looks like as we go into next year, what we can do around recovery, sustaining our services, but also what you know, the funding settlement looks challenging given all of those things that we'll need to deal with as a health board.
Thank you, Glyn. And, you know, we all know about the consequences of COVID with longer waiting lists and bigger backlogs and what have you. So I think those are definitely things that we'll have to cover off in that development session. So thank you for raising that. If no one else has any more questions about the finance report itself, Rob, is there anything that you wanted to say about the Q4 update on the budget?
Yeah, thanks, Pippa. So hopefully the board will be familiar with this approach now. The paper is fully comprehensive, but I'm conscious that's more for the public consumption for readers that may not have had the full history of our approach this year. So the paper is the Q4 update to budget delegations. As I mentioned earlier, the anticipated income has now been confirmed since drafting the report, so that's taken the risk weight there. And then just looking for the board, on the basis of what's presented, the board to confirm the budget delegation as proposed.
Yeah, happy to support that.
Thanks, Shelley. Any other comments or questions for Rob on this?
Well done.
That's great, thank you. So I think we can confirm that the board is content to approve this. And I think we were also noting the what you said earlier about the COVID arrangements and the specific funding around that. So thanks very much. If there's nothing further on that, we move on to the next item on the agenda, which is the performance report. And Nicola, I believe that you're going to present this.
Yeah, thanks, Chair. And good morning, everyone. Nice to see you all. Yeah, so this report provides an overview of performance around some of the key metrics in line with the standard report that we've developed. And they mainly focus on planned care, urgent care, cancer, stroke and mental health. So I'll just kind of pick up some key headlines from the report, if that's okay. So firstly, in terms of, so I'll just take my headphones off. Can you hear me okay? Yeah. So firstly, in terms of planned care and outpatients, I think it's important just to give the context, and especially the conversation we just had around the challenges we've got and the need for transformation next year. But when you look at overall our waiting list, 110,000 people sitting on a waiting list for us, similar to that message we get on an all Wales level, probably just under 20% for us, 77,000 of those at an outpatient stage, and of which 14,000 people waiting more than 52 weeks. The scale of that challenge is just enormous. And I think, the challenge we will have next year is our ability to make real progress into that with the unavoidable commitments and the urgent care pressures that often take our focus and resources. So I just thought that context is important in terms of the challenge that we try to deal with around planned care. But despite that, there's significant amounts of work as set out in the report around the outpatient programme, really trying to look at different ways of meeting that demand, trying to get that right balance between face-to-face and virtual consultations. November's seen the highest number of outpatient activity since January this year, so we are continuing to increase the amount of people that we are seeing. There's also a real focus on the 52-week waiters, where we are contacting patients and checking whether they are still they still want to have their kind of appointment, and trying to do a clinical assessment process, so at least it allows a level of prioritisation. So that work is ongoing, and once we've got through that, we'll start on the 36 weeks. So the outpatient team are very focused on that. And then when you look at the elective side of things, we've got around 23,000 people between the inpatient and day case waiting list, of which just over 8,000 of those are waiting more than 52 weeks. But again, similar to outpatients, we have seen that the highest some increase in numbers of elective, despite the challenges that we've got. And we're around 80% of the work internally compared to pre-pandemic, and recognising we commissioning externally on top of that. And again, November's levels of activity were the highest since February 2020. So really are seeing increases. And, there's no doubt that our model at the minute, where we've got a lot of elective work going on at the Royal Gwent and Neville Hall, and not on the main acute site, is paying dividends, I think, in terms of our ability to keep treating patients. And that's evident when you look at the All Wales position. Everybody's got significant waiting lists, as we all know. And we are the only health board that has seen we've seen about a 12% reduction in those waiting since August. We've gone from about 39,000 over 36 weeks to 35,000, just under, where all other health boards have pretty much maintained their positions. And I think, that is real credit to the teams, and I think the model we're trying to run. Notwithstanding that, huge amounts of work and, to keep, and I think what we'll see is a change in pattern as we go into next year in terms of how that waiting list changes, because the additions are still coming on faster than they're coming off, really. In terms of the diagnostic side of things, all services, again, continuing to increase their levels of activity, despite the challenges we're seeing on the workforce. Endoscopy and cardiology in particular are two of our most demand areas where demand is increasing. Endoscopy is a particular concern for us, and we've got insourcing solutions in place for both cardiology and endoscopy, whilst we look at kind of more longer term, and we've obviously got longer term solutions around endoscopy in particular. So again, holding our own, and an All Wales position generally at the top of the pack in terms of the least highest number of people waiting is the best way to put it. But the teams are working exceptionally hard to try to keep on top of that. So the kind of planned care position, I think, definitely see an increased activity despite the challenges, despite urgent care, and definitely kind of, on an All Wales front, kind of at the top of the position there, really. But lots of pressure on us as we say, well, we're going to be able to deliver lots of non-recurrent money this year that we are trying to throw everything at. Rob is constantly reminding us of, do what we can this year, recognising it's more staff we need, sometimes more than the money. But the ability to sustain some of this into next year in an affordable way is going to be the challenge, I think. Moving on to urgent care, as we know, urgent care continues to be under significant pressure, both in terms of increase in demand, the acuity we're seeing coming through, and increase in numbers of self-presenters. And alongside some of the most significant workforce challenges I think we've seen, particularly in December and January. I think following on from the kind of enhanced care, our length of stay is at the highest point since June 2016. That's where, that's the scale of the challenge. And I think that's symptomatic of the wider system challenges. We know the staffing issues and capacity of social care, the COVID rules, and, in terms of our ability to move and discharge, and the acuity of patients that we were talking about earlier as well, all having a contribution to how length of stay is driving up. And that's where I think some of our key opportunities going into next year will be, in terms of how can we manage some of this differently, cohorting patients appropriately. I think it's also worth just mentioning in terms of the emergency departments and ambulance. We know ambulance have been under significant pressure. They face the same workforce challenges as the rest of us, and have regularly had to escalate to different levels of response. And we know what happens is when ambulances can't get to people, they come direct to the A&E department themselves, which often loses our opportunity to redirect them somewhere else or manage them differently, and often can result in more urgent people in the waiting room than those on the ambulances outside. So it continues to put pressure on our ability to offload quickly. So it's a vicious circle because we're all facing significant pressures, really. But just our 4 and 12-hour performance. Sorry, if I pick up the handover delays that is mentioned. So and Gemma mentioned it earlier in terms of ambulances as well, and long waits in ED. Our ambulance handover position is still pretty poor. We still got over 700 people in November waiting more than an hour. The position has been, if you look over the last 12 months, has been fairly static, the number of people waiting more than an hour. It's not particularly getting worse, albeit some of the health boards have seen big deterioration in the last few months. Everyone is really feeling the pressure on this across Wales, but we seem to be holding our position more than it deteriorating or improving. And there's huge amounts of work going on across with the teams and with WAST and colleagues to look at how we can improve that. And we've got cohorting vehicles now outside. We're also continuing to look at the flow centre. We're constantly working with WAST regularly every day to look at how we can improve on this particular area. But as I said, the symptom of often having more people self-presenting who are more sick is the constant challenge for the ED team to prioritise appropriately. But it's a key priority for us in terms of improving that. In terms of 4 and 12-hour performance, our 4-hour performance improved in November. And whilst it's not in the report, our December position improved even further. We've gone up to 74.1% in December. If you take Powys out of the equation, we've actually got the highest 4-hour performance position in Wales for December, which I think, given some of the bad press we had earlier in the year, is a huge achievement, albeit it's not where we want to be and we want to get better than that. And it's useful to understand the split. So the Grange varies between 55 to 60%, and there's about 7,000 people a month attending the Grange. But there's over 5,000 people attending our minor injuries units a month. Most of them are in a 98% seen within 4 hours, consistently over 95%. So really are seeing an improvement, despite having some of the biggest challenges in the last month or two around Omicron and the challenges that's brought. And some of our workforce challenges in ED has been significant. So to achieve that in that context is really good, to be honest. And some of us monitor it daily. I know Glyn does as well, but January so far, and I'm not going to speak too soon, hopefully, but, is even better than December in terms of our performance. And I think there's about 7 days I've seen so far in January where we've hit 80% on those days across the health board in terms of 4 hours. So there are green shoots of improvement, I think, which recognises all the efforts of the system work everyone's doing and the challenges around length of stay. 12 hours, again, still a key concern for us. Over 1,400 people waited more than 12 hours in November. It was an improvement on December by about 300 less, so again, going in the right direction. And in December, that number's down to 1,200. So again, continuing to come down in the right direction despite the challenges. But all of these is linked to our work around system flow, average length of stay, transferring patients. So it's a huge piece as part of our urgent care transformation programme. So they were the key headlines around urgent care. Cancer services, again, a key priority for us to be able to maintain a robust cancer service. We did actually see a reduction in referrals for the first time, I think, in November and December. Some of that we think is symptomatic of Omicron and often, less people presenting and ability to workforce challenges and so on. But we did see a reduction in GP referrals. But our activity, despite the challenges, is still above our kind of pre-pandemic levels. And even though we saw reductions in referrals in areas like breast and colorectal, they are still way above the pre-pandemic referral levels that we've seen as well. So some of these specialties are continuing to increase our referrals and putting significant pressure on things like endoscopy, which is a key challenge for us as well in terms of hitting our single cancer pathway target. Which again wasn't quite as good as it's been in previous months. And the more we see the backlog, the worse the performance is, because they only get counted in the month they treated, if you know what I mean. So again, big variation between tumour sites, but again, lots of work going on with the team. We continuing to offer a very good response given the circumstances on cancer, and we have got one of the lowest backlog levels in Wales, second to Cardiff. So recognising there's still lots of work for us to do, particularly around that outpatient and diagnostic part of the pathway. We also have had a number of challenges around some cancellations for some of our more high-risk cancers that need to be undertaken at the Grange. And I think this, again, because we've had to cancel a number of cases, which we have constantly looked to then rebook because of the pressures at the Grange. So trying to get that balance between access to cancer and urgent care at the Grange is a key issue that we're working on as well. And then picking up stroke briefly, whilst we're doing quite well on access to a stroke consultant within 24 hours, we're still not doing particularly good in terms of accessing direct access to a ward within 4 hours. And our speech and language therapy access is not as good as we need it to be either, although it's a similar picture across Wales, really. And we've recently taken a decision. One of the many decisions we've taken in terms of funding is to invest in the speech and language therapy support at the Grange to support a number of these specialist services. So we're hoping we will start seeing an improvement in that as we go forward. And then finally, in terms of mental health, done particularly well around the CAMHS access to within 28 days for first appointment, 100% achieved in November, which is really good. Consistently hit the target, but actually got 100% in November. Our access to the neurodevelopmental pathway is improved in November, but we're still not quite at the 80% that we need to be. It's currently around 76.8. But again, lots of work going on in the CAMHS service. And we are seeing the benefits now of the SPACE project, the single point of contact. But lots of work to do still around the neurodevelopment, around streamlining. Have we got the right balance of face-to-face and working through those backlog of patients? Primary care mental health, I'll pick out sustained performance of over 80% in the 28 days for assessment. We have intentionally targeted our resources into getting through the assessments, but we have then seen the consequences of that on our interventions that are now still quite a bit below our target. Doing what we can around Attend Anywhere and the Mello website and things like that to try to mitigate some of those risks. But it is going to be a key focus in terms of how we get those interventions back on track as the workforce capacity improves. So they were the main headlines I was going to pull out, Pippa, and happy to take questions.
Thanks, Nicola. Any questions, please, for Nicola? Leanne.
Hi, not a question as such, just a few supplementary points, if I can, please. I think just for board assurance, I wanted to share with you that there is work ongoing in relation to the cancer cancellations at the Grange in particular. There's a forward plan that is looking at the pre-assessment process and also the overnight cover at the Royal Gwent to enable us to ensure those patients are being done sort of in the most appropriate setting, which we believe will make a material difference in terms of those numbers. They are very, very small, but I think just to reinforce, I guess, sort of the efficacy of the post-operative care unit in the Gwent and how that has allowed us to continue sort of with elective operating more so than lots of other health boards. And I think just reassurance in relation to the overall sort of clinical futures model. So obviously we take a risk-based assessment of delivering our activity. So it is very important that if we are aware of cancer cancellations, we're doing our utmost to avoid them or mitigate them and put a forward plan in. So I just wanted to provide that assurance to board. And then just two things of note. One Health Board initiated, one Welsh Government initiated, but will inform it will inform definitely our future direction of travel in relation to sort of service delivery. So getting it right first time is a national model of reviewing sort of services. An independent expert panel comes in to assess against sort of set standards. We have initiated that for stroke services ourselves to assist us, I think, sort of informing future direction of travel. But Welsh Government have also commissioned a number of these reviews on an all Wales level. So we're just in the process of engagement. There's a visit planned for orthopaedics in early February. So these reviews, I think, will, as I said, set out, I guess, sort of the roadmap for service delivery and certainly the expectations of standards that they'll expect us to adhere to from performance and how our services are developed. So just wanted to share and add those things to the report. Thanks.
Thank you, Leanne. And I'll come to you, Paul, first.
First of all, to say, Nicola, it's an excellent and comprehensive update, and I think to put it on record, huge thanks to you and the team for all your exceptional hard work. It's really helpful, I think, to by you giving some benchmarking data, but other health boards as well, because it just gives us an understanding of where we are compared to others, and that's always helpful. And I just wanted to thank you for that. And I think the background of staffing challenges, we've got to put that into the equation as well. The area that I am still concerned about is the ambulance service and the sort of 111. And I just wanted to sort of seek your sort of thoughts on, you know, where, because we were going to have, I think, a deep dive into the ambulance service and the 111 services to see whether the 111 was sort of actually taken on board our situation at Aneurin Bevan. Any thoughts with regards to that, or have you seen improvements?
I don't know if Leanne wants to come in to discuss that, because she's working obviously more closely with West and constantly monitoring the 111 activity and performance.
Thanks, Paul. It's a great question. 111 is obviously really important in terms of how patients access our urgent care system, and we have put in place, certainly over this year, a whole system approach to managing our urgent care pressures, and I think that's a really important point to ensure patients get to the right place. We have had significant problems with 111, and I know Gemma has shared sort of concerns in terms of public confidence of accessing that service and some of the abandonment rates that we were seeing. So we monitor this sort of regularly in terms of the calls going through 111 and how they're routed into the system. The position in relation to abandonment has improved. The target is 5%, but we are nowhere close to that. At some points during sort of the peak, I guess, sort of periods, we were seeing abandonment rates in excess of 40%, and there were particular times of the week that they were really hitting, weekends in particular, because of sort of staffing problems. As I said, that abandonment rate has come down, and in fact we had a discussion this week. You must be psychic, I think, because we had a discussion this week about, is it time now to reinforce that public messaging again and to ask people to engage with 111. It was felt that in spite of the improvement of the abandonment rates, that the system was still not robust enough, I think, for us to do that. And what we can't afford to do, I think, is ask our public to engage with something that we can't assure ourselves they can deliver on. So, and in addition to that, there is a wider context in relation to 111 and some other services going live in Cardiff in the coming months. So the 111, our local team, excellent sort of leadership from Alice and Bex Pierce, have been engaging directly about testing that for us. But I do think your point in relation to, I guess, a deep dive, I think would be really a good thing to do, because I think with our flow centre model, we have an opportunity to influence that for ourselves. We are fortunate in relation to the navigation system that we have in place. And the efficacy of that, albeit, as I said, I think that's something that merits a discussion for us. In relation to the ambulance position, there is an inordinate amount of work that is ongoing because of the seriousness of that.
There is daily risk assessments, and Nicola's already alluded to the cohorting vehicle. There's been sort of the additionality that we've got, but we have seen an improvement in that, in spite of, I think, some of the challenges we've had around the back end of the system, I guess, sort of the discharge profile for some of our patients. So it is whole system, plenty more work to do, but a very, and I think, again, just to reinforce, recognising there are limitations to our ability to improve to the level we would want, but there is a risk-based assessment in relation to those ambulance delays. So, for example, the red release, when an ambulance is required to respond to a red call, during January, the audits that we've undertaken is that there have been no, not refusals, but inability to undertake that red release. So lots and lots of work ongoing, but please, just to assure you of these, I guess, sort of focus on this because of how important it is from a risk perspective.
Thanks. Yes, I just follow up with that. Sorry, Pip, but I mean, you know, we commission the service, and we expect the service to perform. And I think that, you know, if we say to people, can you, if you are unwell, can you try and do something for yourself? If not, can you go to the pharmacist? If not, ring 111. Then suddenly there's no confidence in that particular situation because they can't get hold of the person, or there's some issues with regards to it. You know, we just need to make sure that issue is addressed, and I'm glad that it looks as if you are addressing that, which I think is important. And similarly with the ambulance model as well, because there was a disconnect between what was happening in other parts of Wales and what was happening specifically for Aneurin Bevan. And the question I think I was trying to aim at was, have we been assured that what we have requested in terms of our commissioned service is now being provided?
Again, another great sort of follow-up question, Paul. There is a paper, again, I think sort of your psychic ability is amazing me today. There's a paper I've got for review that I'll be bringing forward to execs in relation to the commissioning of our services with WAST, because I think we undertook, as you will be aware, as part of the Grange opening, we commissioned additional capacity to allow us to transfer patients around the system as part of the system change. We have to piece that together with our bigger contract, because I think there are fundamental issues in relation to our patient needs and requirements and for our population, but it needs to be looked at in the round. And just as an example of that, we've got much more transparency in relation to availability of vehicles and the types of vehicles that we have that I don't think that we had probably even 6 or sort of 9 months ago through some of the processes that we've put in place. So as I said, lots of focus, work in progress, but a structured approach to assess our patient need and requirement, I think, is the key next action for us in relation to WAST, alongside the process changes that we're making in the system.
Okay, thank you for that. Very helpful.
Thanks very much. And I think we will be looking at our contract with WAST and WAST performance in some depth in the future. Helen, I'll come to you next if you have a question.
Okay, thank you very much, Chair. Thanks very much, Nicola, for a really comprehensive report, and then for the updates over the last few months. That's really encouraging to see some of the positive things. Also good to hear about the getting it right first time. Mine was a really fairly minor question, really. Obviously, the surgical waiting lists across all the specialties are being classified onto urgency, but then interesting to see that you say that still quite a number of patients, despite having sort of got to the priority and being in the top priority, are then cancelling or declining surgery. And I just wondered how that's then managed. Do you then put them back down the waiting list, or do you go, you know, how many times do you offer them, you know, options for further surgery, you know, and to manage those that are perhaps of lower priority and are missing on opportunities who actually, you know, want or need the surgery?
Yeah, can I pick it up? Yeah, that's okay, that's fine. So I think because of the risk-based approach now, there'll be an individual clinical assessment in relation to that around the urgency, and I guess sort of understanding the individual patient circumstances around sort of cancellation. It would, because I guess because of some of the change in COVID, that risk-based approach does really, I think, sort of place it back with the clinician to make a decision. We do give patients the option clearly of coming off the waiting list. If they are removed from the waiting list, though, a letter will always be sent to inform them of that, with an option about reinstatement in relation to that. But the assessment of where they would be placed and when they would be treated would be a clinical one, because of the risk around it.
Thanks very much. Thank you.
Thanks. Tej.
Actually, my question was on something very similar. Firstly, thank you, Nicola, for this report. It's very comprehensive, and I just want to acknowledge the enormous amount of work that's being done in very difficult circumstances with limited capacity. So thank you for that. My question is around prioritisation of patients in exactly the way you've just described, Leanne. I note, I'm sort of homing in on the elective care section of your report, Nicola, and I note that we are monitoring implementation of the prioritisation framework. I'd like to know a little bit more about that. But also, so what that means is that, as you say, patients are assessed for clinical need and supported and treated in that way. But we're also measured against our RTT. So I'm just wondering how we balance those two things. And also, if you could just give us a bit of information as to how the assessment of need is done. In other words, so somebody is assessed, when is that case revisited? What sort of period of time, or is that purely based on that condition and that individual or that clinic, possibly? I'm just casting my mind back to the conversations that we had with Gemma at the beginning of this meeting around people with cataracts, waiting for cataract surgery, and clearly people are moving up that prioritisation list. Most people are willing to wait, but clearly once it starts to impact on their lives, and that is something that they're going to worry about. And I think if people understand better how the lists work, I think that would very much help.
I think before you answer that, Nicola, I've got Gemma is waiting, and I wondered if she was going to touch on the same point. Gemma?
Slightly separate point, so I'm happy to wait. Thank you.
Okay, thanks, Nicola.
Yeah, I'll see if Leanne also want to, in terms of the operational process, but just in terms of that conflict between the 36 weeks versus the prioritisation, I think the guidance has been really clear that the focus is on the risk, not the waiting time. So all of our effort is on the, those R1s, R2 priority groups, and going in that order, and then the wait, is the wait, and that's why we've spent a bit of effort as well then on the over 52-week waiters, just to check whether people are still, suitable, still want to be on the waiting list, and maybe test the clinical assessment in that area. But the 36-week wait target has such become redundant in the current situation, albeit we are closely monitoring to understand the risks in the system, because as you said, people will move through those risk groups as time goes on, when they so. Leanne, do you want to pick up? I'm not really close to the operational process of scoring them and testing them.
Yeah, sure. So a couple of things really, just to reinforce. So we prioritise the use of our capacity, which is limited and still not quite back at pre-COVID levels of activity across the board. There are some services where that is not the case, and we are back at those levels, albeit we've done sort of very well. But when we prioritise the use of capacity, we target cancer, suspected cancer and urgent for new outpatients in particular, and R1s for ophthalmology for all surgical and non-surgical specialties, including therapy. So there are very distinct, I guess, sort of classification and guidance that's come out in relation to that. It is down to individual clinicians in relation to assessing the risk. And when the categories came out, the individual clinicians were asked to assess their lists. the expectation is, certainly since I've from my teams, and is that some consistency and some oversight at directorate level, that those clinical decisions are reasonable and that there's no clinical variation between the teams in terms of how that's being assessed, because I think that possibly will have been a concern sort of in the past and remains one. So we need to be equitable in terms of how we're applying sort of that risk assessment. The only exception to that, I think I would say, which we've done pretty well on, is routine diagnostics. And just to share again, I think though we are taking a risk-based assessment of our utilisation of our capacity. When we've looked at some of the work that we've done and audited in the past, particularly when COVID first hit, the number of cancers we were picking up in routine scanning were as high as those that were coming through in urgent suspected cancer sort of diagnostic requests. So we have continued, in spite of the fact that they've been rated in the first instance by the referrer as routine, we've continued to undertake that activity or not pull back on capacity for those because of the pickup rate and the assessment of risk around that. So it's down to individual sort of clinician assessment on the basis of the patient's need and requirement and clinical assessment at that time. The recommendation from Welsh Government, and this is where I guess sort of the tension lies at the moment, the recommendation from Welsh Government is that patients undergo a regular clinical review to assess or update some of that information if their condition has changed, if the prioritisation has changed. And that's a real challenge for us to undertake, because that clinical review effectively takes away clinical capacity that actually could be treating the patient. So we have been prioritising their time to treat and see patients as opposed to undertaking the clinical review. There are, however, other ways in which patients can update us around changes in condition. So one of the things, for example, that I've asked the ophthalmology team to do, so we have great, most of our referrals come in via sort of local optometrists from the community. So they are a great source of intelligence for us if there's been a deterioration in condition. And in fact, my mother-in-law is a great patient story in relation to that. Went for a review, was down on the list for a cataract, has been reviewed by a local optom. Her clinical condition has been updated locally and she's been offered a date. No favours pulled in, completely independent, and actually will be accessing Emerson Green just as a follow through from the conversation earlier on. So real, I guess, success story in relation to how we are assessing the risk on an ongoing basis. But I think I do need to just reinforce we are in a capacity poor or limited system, and where we target and that resource I think is really key. So we've made an active choice to target that clinical sort of assessment or time in terms of treating the patients rather than the clinical sort of assessment.
Thank you, Leanne.
Could I just follow up, Pippa? Sorry, could I just very quickly?
Sorry,
very quickly. Thank you for that. And I think that assurance that we are working to a framework, we know that, but I think the public really need to know that. We know that, they know that there are capacity issues. And I think that assurance is really important. And then the other very quick point is great to hear about that example about the optometrist. And I think that is what I'm referring to when I was talking earlier about that wider healthcare ecosystem and making the absolute most of the resources that we've got there. So thank you.
I think just to come back, I think there is a real danger if we don't work in a whole system way in relation to this. Patients will bounce around the system and in frustration, understandably, and capacity is so limited across the whole of the system. Sort of coming up with ability, how we communicate with our patients, how they update us in relation to sort of their current position, and how we gather the most up-to-date clinical and sort of personal information so that they can access their treatment in the most expedient way, I think will be key. We've still got more work to do on this, but it is absolutely front of house in relation to sort of how we're assessing and sort of working with patients and our clinical teams.
Thank you. I think we've probably got time for 2 quick questions. And Shelley, you've had your hand up for a while.
Yes, it was just a question right at the end of the report. It was really for Nicola in relation to outcome measures. And obviously I can see there, you know, we're using 2 outcome measures at the moment, but I just wondered where we were with the outcome framework that was going along to support the annual plan.
Yeah, thanks, Sherry. I was going to pick it up, but then I thought I'll wait for your question. No, there's yeah, as we said, we're going to try to wrap this up as part of the IMTP and the delivery framework going into next year. Welsh Government have also been doing work on this, so we felt it was sensible to await their phase 1 measures so that we can align our own kind of plans and ambitions with that. They have now issued that last week in terms of their kind of phase 1 measures. I think they are constraining them to a certain extent to what information they know is available. So they're not going to probably quite meet our ambitions, and we'll also be constrained by what's available. But what we're going to do is use the Welsh Government ones and then build our own framework around that and start sharing that with you in the board briefing session next month, with the intention to get that delivery framework up and running for Q1, so that we would have a Q1 next year without kind of, you know, even if we can't complete all of the information straight away, at least we've all kind of agreed what those key measures are. And some information will be quarterly, some will be monthly, some might be annually as outcomes. For example, the cancer outcomes report comes in once a year. So, you know, we just need to align with when some, you know, lots of clinical audits are once a year. So we just need to kind of work together on what's high level system measures versus what's more specific specialty level outcomes, and what's more kind of patient, carer, prems type outcomes. So yeah, we're starting to pick up that work again now once we've got the IMTP off the ground, and we've now got the Welsh Government phase 1. I'll send them over to you, Shelley, if you want, just so you can start having a look at what we'll get them sent round.
Yeah, I think that, sorry, Pip, if I can just come back, I think that would be really helpful, because I know we had a conversation with the chair, and some of the measures that she's going to be measured against are not what I would call outcome measures. So again, I know you might have to complete those, but it would be lovely to just see more outcome measures in our own individual local framework here, which I think is probably what most of us are looking for. Thanks, Nicola, that's great.
Yeah, thank you.
And I think that would be great if you could share that with the whole board for information as well. Thank you. Finally, Gemma, to you.
Thank you. Just off on a similar theme to others that have pointed out, the patient cohort who are cancelling their own elective procedures when they're offered, the CHC will be prioritising a piece of work with the health board about understanding whether there's a socio-economic impact that's influencing people's decisions to cancel, because we know that the drop downs to cancel somebody is quite limited. So we're going to be targeting the individuals who selected date not convenient and understanding whether it is because somebody's on a 0 hours contract or they're a carer in the community. So come next quarter, that'll be a key focus for the CHC with that group.
Thank you very much. And actually that ties into the work of the PSB as well, doesn't it? In terms of how that fits against the background of the people within our communities. So I think that'll be a really important piece of work. If there's nothing else on the performance report, we move on to the strategic risk report. And Glyn, do you want to pull out any details of this?
Yeah, thank you, Chair. I'll just pull out some sort of key highlights in terms of this particular report. So this is the, as you say, this is the strategic risk report. So it covers off the corporate risks, which the board sort of need to have an oversight and ownership of. You'll see there are sort of 24 strategic risks, but when we've actually sort of scored those, there are 15 that would score as particularly high, and those are the ones that the board and some of the subcommittees will need to pay the most attention to. Board members will also note that we've revised the reporting dashboard, so hopefully people find it easier to navigate their way around the key risks, the actions being taken, and how we're actually handling those risks as an organisation. undoubtedly things like the COVID pandemic have had an impact on our services, and to a certain extent you'll see that reflected in our assessment of some of the risks, some of those key risks, and how the pandemic has actually impacted. We have, as an executive team, taken a view that there are certain risks that can probably be de-escalated, and again, those are set out in the report. Probably the final point really is just to sort of emphasise the point that actually these risks are sort of considered and reviewed through our assurance committees that we have in place. So as well as having a responsible sort of owner for each of these risks, our assurance committees also spend time looking at how we're managing these risks and whether they're being reported and dealt with appropriately. So that's probably all I really wanted to say at this stage, Chair, but happy to open it up for questions or comments. Thank you.
Thanks, Glenn. And first of all, I think that the way they're presented is definitely clearer than it has been in the past. So thank you for that. Have we got any questions for Glenn on this? Shelley?
It's not a question, and it's Glenn. It's just to thank you very much for the report, but also if I could just put on record my thanks to Rani and to Danny as well for the way that they're really pulling this all together now, because as Pippa said, it is easier to understand it. And I think the fact that we know we have assurance committees that are able to spend a bit more time looking in detail at some of these risks, and hopefully the plan would be that we might do some deep dives on some of these risks at that level. I think that will just again embed the whole process and procedure within our health board. So thank you very much.
Thanks very much, Shelley. Keith, you have your hand up.
Yeah, you're going to have to excuse me. I'm going to have to leave. I have to go to another appointment.
That's okay, no problem at all. Thank you very much for attending, Keith.
Thank you. Bye-bye now, all of you.
Bye. Sarah, you have your hand raised.
Thank you. It's just to highlight the specific change in the report around the risk in terms of recruitment and retention, and that's just based on an assessment of the current recruitment market, whereas previously we have historically had specific issues with specialised or specific categories of professional staff. Whereas given the impact of COVID and Brexit and the high level of general vacancies across our area and indeed across the UK has altered that risk, where we're now seeing different challenges in different ways, and therefore need to ensure that our actions to mitigate those risks for all categories of staff are encompassed in our risk assessment.
Yes, thank you, Sarah. Paul?
Just to say, I think that the document is incredibly helpful, and when I looked at it's got which committee are responsible, and I'm sure that Rani will be, when it comes to the agenda setting, that the risks will be sort of high on the agenda for the particular committees to make sure that we spend some time, looking at those particular issues, and then because that's then reported on to the audit and assurance committee. So I mean, I think that it is incredibly helpful to have that sort of plan on a page, or two, so to speak. Really helpful.
Thank you, Paul, and thank you for expressing it so clearly as well. It's really appreciated. Are there any other questions about this? I think we just have two things really around the de-escalation of the risks outlined in the report and the two that we need to remove. And I just want to know whether the board is happy to support the de-escalation and the removal.
Yeah.
Great, thanks very much. Then we'll move on to the executive team report from Glyn. So I'll move to you first.
Okay, thank you, Chair. And again, it's a real pleasure to present this report. It's been quite difficult to keep this report as concise as it is, because I think there's a lot going on. There's a lot that I'd really like to sort of tell the board about. So I've tried to sort of do that within this report. I'll perhaps just draw out one or two things from the report. Although I think everything's probably worthy of mention really in here. we've talked a little bit already about the sort of systems pressures across health and social care, and I guess it's just important to remind people that it's still busy, I think, is the message really. And although we're seeing things like COVID infection rates coming down in the community, the number of patients in our hospitals is still quite high. And I think undoubtedly the vaccination programme has helped in making sure that not as many people are coming into hospital and presenting as seriously ill. We are still seeing a number of people coming into hospital as a result of COVID. So our health services are busy at the moment, and I think that's very much the case across all of our services. And we'll no doubt see some of that demand start to increase as we hopefully move out of this sort of response phase of COVID. I wanted to, in that respect, highlight some of the areas where we've applied what's called the local options framework. And again, it's set out in the report, but I thought it was important to highlight to the board that we have taken some decisions around temporarily suspending certain services in order to prioritise our resources, particularly staffing resources, around those areas like urgent emergency care, sort of earlier on around the vaccination programme, and to make sure that we could redeploy staff resources to those priority areas. So you've got a list of some of the areas that we took those decisions over the last few weeks, and probably just important to say that for some of those we will continue to suspend some of those services through to the end of this month. It's pleasing though to be able to report that the temporary centralisation of midwifery services at the Grange, we've been able to reinstate those services, which started on the 17th of January. So I think it's a good example of where we've had to make a temporary decision to redeploy staffing resources to make sure that we prioritised the sort of the high risk areas of our services. That seems to have worked really well, and we've been able to return that service back to normal fairly quickly. So you'll see in the paper that we've taken decisions around reducing elective orthopaedic capacity. In terms of mental health services, we also redeployed some of our staff from the primary care mental health services to support inpatient services and crisis teams where we were seeing some fairly significant staff shortages. And the other area just to note is the temporary postponement of some of our routine outpatient appointments, and that's until the end of this week. And again, we've very much done that on a bottom-up review of where we felt it was clinically appropriate to postpone some of those routine appointments, knowing that we could usefully redeploy staff into areas that we were prioritising, like urgent and emergency care pressures. So I hope that's helpful in sort of just informing the board of those areas where we've made those decisions. The third area that I just wanted to pick up on, if I can, which is always a pleasure to do, is obviously this report, timing-wise, fitted quite neatly with the New Year's Honours announcements, and obviously it's really pleasing to announce that we had some staff who were recognised in the New Year's Honours, and again those are set out in the paper as well. So I just wanted to mention that to the board, and obviously to congratulate those members of staff who quite deservedly have received those honours as well. So those are the areas that I wanted to draw out from the exec team report. There is another area that, because of timing, wasn't an issue when we were producing this report, but I did want the opportunity for the board to be brought up to speed, and that's to do with a TB outbreak within our health board area. And what I may do, if it's okay with you, Chair, is invite Dr. Sarah Aitken just to provide an update on that outbreak so that the board are fully aware. Thank you. Thank you very much. Sarah.
Thank you, Chair. So the board were made aware last week that an individual unknowingly attended Blackwood Comprehensive School premises while infectious with tuberculosis, known more commonly as TB, and working with Public Health Wales and Caerphilly County Borough Council, we identified just over 200 students and staff who were considered to be at potential risk of having been exposed to the infection, and who we have therefore offered screening to. That screening took place yesterday, and I'm very pleased to report that there was a 92% uptake of that offer, and it all went very smoothly. We implemented a helpline, a bespoke helpline for students and staff and parents to phone for questions, and we obtained consent through an electronic process for the first time, and we've also will be communicating negative results electronically as well. So we've done a number of things in the management of this that are all learning from the pandemic, and our new strategic communication leads for population health has had a bit of a baptism of fire in terms of working with Public Health Wales and Caerphilly Council public relations officers in terms of handling this. And from my own position, that has made quite a significant difference in terms of we had an extremely tight plan that was timed literally to the minute, and things went out in exactly that order. And I gave an interview to BBC Radio Wales on Thursday evening, but other than that, it's all gone unremarkably, really.
Oh, that's very good to hear, and let's hope that the test results come back negative for for everybody. Let's hope. So thank you.
Indeed.
Are there any questions for either Glyn or for Sarah? Paul?
First of all, to say huge thanks to Sarah for the update, and I'm glad that's been sort of looked at in a very sort of pragmatic and sensible situation. So because I think that tuberculosis is a particular worry for young people, etc. And it looks as if the work that's been done to resolve that or look into it has been exceptional. So well done to staff. Regards to that, I just wanted to say huge thanks to Glyn really for the report. Originally, we didn't know whether we wanted these sorts of reports, I seem to remember, but I think it's a fantastic sort of opportunity to look at some of the issues that would normally be looked at in board reports, to offer recognition and congratulations to people who've done exceptional work for the organisation and deserve recognition. And if you look at that list, it just shows a fantastic work that is being done. And the other issue for me was so pleased to hear the government funding for the Unified Breast Unit, with the work going to be undertaken I think in February next month to start building, which I thought was again great news. Very pleased to see the equality and diversity update, and I think it's important that we do look at that in terms of our entire community, and we sort of are inclusive with regards to that. And the one area I did want to focus on was the communications and engagement work, because again, that has been exceptional. The road shows have been exceptionally well received. The social media work, again, has been excellent, and the animation that's coming out, I think, is well worth seeing. So all in all, I think it is worth us continue to have these reports, Glyn, and well done to you, because obviously you've been our interim chief executive and doing a superb job. Nicola, similarly, Rob, equally. All of you are doing a great job at this very difficult time, and just to thank you for all your hard work.
Thank you, Paul, and I'm sure the board would echo that sentiment. Do we have any other questions for Glyn or Sarah? Phil?
Yeah, just a comment on the integrated care facility, which at Hollyward, which I think is an interesting development. I just wonder whether we could have a more detailed, perhaps short paper on that, maybe at the strategic planning meeting, because I guess one of the concerns about such a development is that it's managing the throughput, I guess, and it's a multi-agency issue in terms of managing the throughput. We may even need some kind of link going back to the regional partnership board around these kind of developments, because what we wouldn't want is bringing on stream more beds that then get full because they don't have people to go. I'm sure that the execs are very, very well aware of those difficulties, but I just think it would be worth keeping an eye on this and at a board level, just to see the success, or conversely maybe to look at maybe some of the difficulties with it. But I think it's a good development, but I think there are some dangers within it, as I'm sure we're all aware.
And I'm sure that we can receive some ongoing information on the outcomes there. Sarah, did you want to say something?
Yes, thank you. So it's a development as part of the Step Closer to Home pathway in order to help facilitate patients to progress along that pathway. And I have been regularly briefing the community care group, which is the emergency structure under the regional partnership board that we've agreed as part of the winter plan governance. So there is that line through to the regional partnership board through that group, and that pathway is owned by that group. So I think it's important that we see it as a really important development in terms of making that pathway work smoothly.
Yeah, agreed. Thanks.
Great. Thank you, Sarah. And I have to say, well, thank you very much to Glyn and all of the staff, and really huge congratulations to all of our staff who've received not just honours in the New Year's Honours List, but also other awards. And I think the other thing, there are lots of staff who aren't receiving awards, but who are putting in, unstinting effort on behalf of patients, really to provide the best care. So I think as a board, I think we should really pass our thanks on to everybody for that. I think it's really quite remarkable what our staff do. Yeah. If there's nothing else on this report, then we'll move over to the committee papers. I guess it's just a question. Obviously, the information is there for people. I'm assuming that they've read it. And I'll go through very briefly. Shelley, do you have anything to... Oh, sorry, Tej.
Sorry, Chair. I noticed that the Charitable Funds Committee assurance report isn't in this pack. I thought I'd seen it, but that's because I read it before it was submitted. So I apologise for not bringing that up earlier when I read through the papers, but it's not in this pack.
No need to apologise, and I think we've had such a comprehensive review of the annual report of charitable funds as well that I'm sure nobody will mind that it's not there. So thank you, Tej, and it can be circulated after the meeting. So I'll just check through very quickly. Anything from you, Shelley, on audit?
No, nothing that's not on the report. Thank you.
I did Mental Health Act Monitoring Committee. There was nothing there that isn't in the report. The same with patient quality, safety and outcomes, and the strategic planning meeting as well. I'm not certain. I don't think there was anything there. Nicola, was there anything that you wanted to add?
Oh, sorry, it was just on the quality and patient safety and the WCCIS implementation. I thought I could give a verbal update because things have been moving quite quickly, and the team have now, as a result of the work with the national team, rescheduled a go live for the end of March. So subject to everything going to plan, which we know can change, but we've currently got a new reprogrammed go live now for the end of March, and are working closely with the mental health teams and then the national team to work to that date.
That's great, thank you. And Glyn, I think you can confirm that we have invited WISC to a board development day?
That's right, yeah. So the last joint committee of WISC was sort of considering the if you like the specialist service part of our IMTP or 3-year plan. So we've invited WISC and ESC, which is the Emergency Ambulance Service Committee, to a board development session. I think they're both in February, where we'll have a chance to look at those priorities as part of our wider IMTP.
That's great, thank you. Any comments or questions about any of those reports? I'm not seeing any. So that concludes our business for today. Paul?
Just to say a huge thanks to you, Pippa, for your work today. I mean, we've had a very, very detailed agenda, and, you know, huge thanks to all the people who put all the reports together, and to Rani, our new board secretary. And it's been a great meeting. Just to say thanks to you, really.
Oh, thank you, Paul. Very much appreciated. And our date of our next meeting is Wednesday, 23rd of March, 2022, 9:30 in the morning. Diolch yn fawr I gyd for attending the meeting today. There's a little bit of blended Welsh, I'm afraid. My Welsh, dwi'n dysgwyr. I'm only a learner, so just a small amount. And that concludes the meeting. Thank you very much all for attending.
Thank you.
We do have an in-committee meeting following this, but if everybody would like to take a 10-minute break, I think that would be really good. We'll see you all in 10 minutes. Thank you.